Good afternoon, everyone. We got started to the breakout session for a young investigator lecture meeting. We have 3 presenters in one session. We have 2 chairs, and we also have judges from APASL and AASLD. So your presentation should, assign some scores to from 0 to 10. Then you might got the award later. So I'd like to start the first session, and the first speaker is Ren Yang from China. Yeah, thank you. And his title of presentation is Exploring Trends in Liver Cancer Causes in China, a focus on hepatitis B and emerging factors. You have 10 minutes for presentation and also 10 minutes for discussion. We ask all audience to make educative and constructive comments for his presentation. Thank you.
Thanks for your introduction. And I'm Dr. Ren Li from Peking University People's Hospital, and I will present on the topic Exploring Trends in Liver Cancer Causes in China, focus on hepatitis B and emerging factors. And we have nothing to declare for this study. And I will start my presentation from 4 parts: the research background, methods, result, and conclusion. At first, let's look at the background, which is the epidemiological data of liver cancer worldwide in the past decade. As you can see, in 2010, there were over 740,000 deaths, a new case of liver cancer global, and the deaths reached about 700,000. And by 2020, the new cases exceeded 900,000. And the deaths reached about 830,000, and both increased by 20%. And among all these cases, half of them were in China, so it's crucial for us to prevent liver cancer by early diagnosis and treatment. As we all know, most liver cancer in China are related to hepatitis B, and which is closely associated with the incidence of liver cancer. Recent reports indicate that the incidence of hepatitis B showed a significant decrease in the past decades. Another cause of liver cancer, hepatitis C, remains stable during the period. And although there seems to be a slight upward trend in the graphic, and the overall proportion is still low. And according to the latest reports, NASH is now the fastest growing cause of liver cancer worldwide. The table on the right shows the annual percent change of the incidence of liver cancer by different causes. As we can see, NASH is 0.88, is far higher than other causes. So let's summarize the background. The current evidence shows the incidence and the mortality of liver cancer are still on the rise worldwide, and the disease burden caused by hepatitis B has declined, and NASH is now the fastest growing cause of liver cancer. So we came up with the question on whether the main cause of liver cancer in China is changing. And to answer this question, we collected the epidemiological data from GDP 2019 database from mainland of China and Taiwan. And joint points were used to plot the trend line and calculate the annual percent change. And both incidence and prevalence are age standardized data, and the proportions are shown as the frequencies per 100,000 people. And let's look at the result. And first is the current situation of liver cancer in China. The graphic on the left shows the trends of incidence of liver cancer in mainland of China and Taiwan. The red line is the mainland of China, the blue line is Taiwan. As you can see, both regions show a significant decrease, first decrease and then rising in the past 30 years. And the first decrease in China was in 1990 and it was around 2004 in Taiwan. And after a continuous decrease, the incidence of liver cancer in both regions remains stable. And the trend of deaths is consistent with the trend of incidence during the same period. And at the same time, the disease burden caused by hepatitis B showed a significant decrease in the past 30 years, which is consistent with the previous study. And next, let's look at the incidence of liver cancer by different etiology. This is the result for mainland of China. As we can see, the incidence of liver cancer by each cause has showed a significant decrease, and the red line is hepatitis B-related liver cancer, which decreased the most. And as we can see, the hepatitis B is still the major part of the disease, and then followed by hepatitis C, alcohol, and NASH. And in Taiwan, a similar trend was observed, and the decrease was in 2004. The virus hepatitis are still the major cause of liver cancer. To figure out the population that mainly affected the disease burden of liver cancer, we divided the patients into 3 groups. And in the mainland of China, the prevalence of the liver cancer in people under 20 showed a significant decrease in the past 30 years. And however, in patients between 20 and 54 or over 55, there was an upward trend in the past decade. And in Taiwan, different age groups remain stable since 2012. And if we focus on the patients over 20, as we can see in both regions since 2012, there was an upward trend in the incidence and prevalence of hepatitis B liver cancer, although there seems to be a slight decrease in Taiwan. At last, let's summarize the APC change in liver cancer by different causes. First, in the past 20 or 30 years, the APC of liver cancer by each cause is all negative, which indicates that there was a significant decrease in liver cancer by different cause, and the hepatitis B-related liver cancer declined the most, and the APC in mainland of China is lower than -4 or -5. And however, in the past decade, the APC of all causes are positive, and with alcohol and NASH, the APC were 2.5 and 2.3, which is much higher than other causes. So we can see that alcohol and NASH are the fastest growing causes in China. Despite the fact that the alcohol and NASH are growing fast, the hepatitis B remains a major cause of liver cancer in China. So we are here, we mainly talk about the hepatitis B. There is no doubt that the vaccine, the hepatitis B vaccine, has played an outstanding role in the prevention and control of the liver cancer in China, especially in children and adolescents. And however, there are many challenges to face. And first, the hepatitis B patients in China is very large and most of them did not receive standardized management and leading to the low diagnosis and treatment rate. And existing treatment can only control or delay the progression of the disease. So in the future, we still need to promote screening and standardized treatment for patients with hepatitis B and improve the diagnosis and treatment rates, and then reduce the occurrence of the end-stage liver disease. Here are the conclusions. And alcohol and NASH as the fastest growing cause of liver cancer in China, and hepatitis B is still the major cause. And it is necessary for us to prevent the transformation of the major cause into NASH. And this is our lab, the Peking University Hepatology Institute, and thanks for all the members in our lab. They helped me a lot, and especially my supervisor, Professor Chen Hongsong, and the director of our institute, Professor Rao Huiyin, and they gave me many advice in my research. And also thanks for your listening. This is all my reports.
Thank you for your presentation. I forgot to introduce myself and my co-chair. I'm Ryosuke Tateshi from University of Tokyo, and I will co-chair this session with Professor Shannan Liu from Taiwan. So his presentation is open for discussion, and is there any comments or, I would like to ask the audience to make instructive comments. Or you can, switch back to your slides to the, specific points when we need we found any room for improvement. So anyone have comments? So I'd like to ask you that there is a significant shift between Taiwan and China. So what is the reason? You partially explained that that might be contributed by the coverage of antiviral treatment for hepatitis B, or might be the launch of the different period of launch of vaccination program.
You mean the reason why I compare the mainland China and Taiwan?
Yeah, because there is a shift, and it looks like Taiwan, slowly the prevalence of HCC slowly decline after China, right?
Yeah.
You can go back to their presentation. できますか？戻せます？プレゼンファイル。
Shoot slide.
Number 10. So it looks like, especially, you shown in this slide that your experience had increase in natural alcohol liver disease in China, but in the slide number 10. Please go back, press the button to, できますよね? Press the button to go back to number 10.
Number 10?
Number 10. This is a title slide, so could you skip? Yes, this is the number 10 slide showing that there is a significant shift between the red line and the blue line.
Yeah.
So what is the reason for this shift?
The reason why the trends of incidence of liver cancer looks different right now. Mm-hmm. I think there, first of all, the vaccine, and I think in China the routine vaccination was performed in 1992. And in Taiwan, it's earlier than us. It's about 1984 or
1986.
1986.
So
sorry.
There might be about 7 to 8 years of difference.
Yeah.
So that caused, okay. The blue line indicate that Taiwanese patients, and the red line in the mainland China. So it looks like, according to your explanation, there might be a decline fast in Taiwan, but it looks like a decline, delayed in Taiwan. Am I right?
Yeah, I understand what you said. And actually, in China, in 2005, the vaccine is totally free. So the vaccine rate is over 18%, mm-hmm. And before then the vaccine rate is lower.
Coverage is different.
Yeah.
Uh-huh. And when I look at the percentage of incidence, in 1989, there is wide difference between the blue line and the red line. So it's caused by the vaccination, or it is caused by other reason. Because the prevalence is different between Taiwan. HBV prevalence is much higher in mainland China, right?
Yeah, I thought that may be related to the population.
Okay.
I will figure out later.
So in the previous slide, you showed there is an increase in alcohol-related associated liver cancer and the NASH associated liver cancer.
Yes.
Do you have any supportive data regarding the body mass index or alcohol consumption between the mainland China and Taiwan?
Yeah, that's a very good advice. And actually, we are now analyzing the relationship between the alcohol exposure and between the alcohol exposure and with the incidence of liver cancer, alcohol-related liver cancer, and the BMI, like BMI, and with NASH associated liver cancer.
So, could you make a comment regarding the?
Because I'm from Taiwan.
Yeah,
Maybe
yeah.
you don't understand Taiwan so much, so I can explain the reason for you. Firstly, the vaccination effect is not coming yet. We are vaccination very early, but the vaccinee is only beneath 40 years old. It's not a hepatoma age. So I don't think the vaccine is the key factor. As Dr. Tadeshi said, the antiviral treatment is very important because in this time we begin to reimbursement antiviral treatment. So it linked to another reason. The nuke delay the time of hepatoma. So during this period, the age of hepatoma in Taiwan has increased. So our patient is become older. In the situation, you use age-adjusted rate. If you use age-adjusted rate, the rate should be decreased because in the standard population, the proportion of old age is relatively small. So decrease maybe not due to the exactly decrease, it may due to the age increase. So I think it's a very background. And in your study, there's not enough data to support the NASH or alcohol is an important factor. So I think the background epidemiology may be more important.
Thanks for your answer. Yeah.
Thank you very much for your very informative comment. So,
Good.
anyone have any questions? Grace, do you have any question regarding this? Okay. So I have 2 minutes left. So,
Actually, Professor Lu remind me of a very important reason, the difference between mainland China and Taiwan. And I have a slide. There is this one. The reason why there is a difference, this is diagnosis and treatment rates. And as we can see, the diagnosis and treatment rate in Taiwan is twice more than in mainland China. So this is a very important reason about the therapy of hepatitis B.
thank you. This is quite important for making a policy regarding the antiviral treatment for hepatitis B patients. And also, you analyzed the GBD database, downloaded and applied the joint points program, right?
Yes.
Yeah. Where you can run that kind of analysis? So you learn by yourself, or your mentor has a technology to give you the how to analyze that GBD database.
I download the data from the GBD and run by myself.
Oh,
Yeah.
that's a good point. Thank you.
Thank you,
very much.
Professor.
Yeah. I'd like to move on to thank you very much.
It's my honor to introduce the next speaker. Dr. Hugh Bass from Vietnam. The topic will be risk factor of prognosis after primary creative hepatectomy in hepatocellular carcinoma patient. Dr. Hugh, please.
Good afternoon, Mr. Chairman, and good afternoon, distinguished guests and colleagues. It is a privilege of me to come here to represent our team to present the study results about the risk factors and prognosis after primary curative hepatectomy in HCC patients in Vietnam. And I am Dr. Ban Trung Hiếu. I am a surgeon in Liver Tumor Department, Cancer Center, Charai Hospital, Vietnam. So I have nothing to disclose. Through the table contents, we have the overviews, aim of research methodology and results, and finally is the conclusion and recommendation from our studies. As you know, according to Global Cancer Registration 2020, Vietnam is among the top highest country affected by the liver cancer. And in Vietnam, the liver cancer is the highest rate of incident and mortality rates in male patients. And we have Vietnam guidelines on 2012 and updates on 2020 for diagnosis and treatment of HCC patient. And you can see for the indication for liver resection, we also apply the resectability with the reserved liver function for those patients. As you may look, this is familiar to the APASL guidelines of 2017, because our guidelines are mostly adapted from it. Actually, we don't have so much data on the outcomes of the HCC patient treatment to make a completed evidence-based guidelines. So that's why we aim to do the research about those patients under treatment to identify the recurrent rates and the disease-free survival time. And the second primary endpoint is to evaluate the overall survival time and other associating factors. So our research methodology is we do the retrospective cohort study with the inclusion criteria with the patient diagnosed with HCC and indicated for liver resection as the first treatment on the tumor has to be completely removed. And the biomarkers, antiviral markers, and the pathological results had to be fully detailed recorded. And all the patients were followed up until 2023 June, with the minimum length of follow-up was 36 months. And the inclusion criteria, including the pathological confirmed not HCC and the loss of follow-up right after surgery. So from the time of 5 years, we have enrolled the 1,704 patients were enrolled in this study. We also recorded the variables with age, gender, viral hepatitis infection, the preoperative AFB level, tumor size number, resection level, removable metastatic lesion, and pathological characteristic with the three endpoints were recurrence, disease-free survival time, and overall survival time. For the patient characteristic, as you can see, our patient has the mean age of 60, which is old, a little old. So most of our patient was male patient. And the most viral hepatitis cause was chronic hepatitis B. And we also recorded nearly half of the patient have the AFB level or greater than 400. We also recorded a large amount of patients with a normal AFB level around 30%. And our study showed that the single tumor was take the most part for 85%, and most of them was large in size, were ranged from 5 to centimeters, take the most part from 47%, and the tumor necrosis with no tumor necrosis around 70%. And we usually perform the minor resection with 61%. And we also recorded that no vascular invasion around 80%. With we also recorded 60 cases of removable metastatic lesions, and most of them were trabecular architectural patients. And we also have recorded nearly 60% of grade 3 Epstein-Steiner classification. and most of patients have the chronic hepatitis. For the recurrence, we have around 65% of recurrence overall, with the median DFS around 9.6 months. And the cumulative recurrent times was 3 years, around 62%, which is a little bit high. We also identify some factors that's associated with recurrence, including tumor number, tumor size, tumor necrosis, AFB level, and resection level. Also vascular invasion, the removable metastatic lesion, and the Edmondson-Steiner classification. For the identify the independent prognostic factors of recurrence, we find the tumor number, tumor size, AFB level, vascular invasion, and removable metastatic lesions. For the factor associated with DFS, we see that the tumor size, tumor number, the necrosis, AFB level, resection level, vascular invasion, removable metastatic lesion, along with the underlying liver disease, histological, and ES classification, including the cross-professional hazards. We found that this is the tumor number and removable metastatic lesions is the independent risk to the disease-free survival time of HCC patient. So this is the summarize of the recurrence and disease-free survival time. We also recorded that the viral hepatitis marker is not associating with the either the recurrence or disease-free survival time. About the overall survival time, we have the median around nearly 3 years, 34.9 months, and the OS rate of 5 years is around 30%. We also try to identify some factors associated with OS, including tumor number, tumor size, AFB level, tumor necrosis, resection level, vascular invasion, removable metastatic lesion, ES classification. And we also identify on the cross-professional hazard models to the tumor number is the independent risk factors to OS. So this is the summarize of the OS. So our study has also limitations. So our study is a single center study, and so the results cannot be generalized in Vietnam. The management of viral hepatitis and cirrhosis after liver resection was not assessed in this study, which could affect on the recurrence and disease-free survival time. Actually, we do manage the viral hepatitis and cirrhosis, but this is the lack of collecting the data from the hepatologist. So it's really hard to evaluate this problem. And the different types of strain of treatment for HCC recurrence after liver resection were not assessed in this study, which could affect an OS. We have the modalities of multidisciplinary treatment after resection, just as if the patient is stable, we can follow up, or with the recurrence, we can do local regional treatment, or even systemic therapy, but were not enrolled in this study. So we have come to a conclusion in this study. The indication of the liver resection should be expanded to HCC patients with resectable tumors regardless of size. And the liver resection could offer better outcomes to HCC patients. And pathological prognostic factors should be considered to predict outcome of HCC patients, which a lot of hospitals in Vietnam neglected these factors. Thank you for your listening.
Thank you for your excellent presentation. Also thank you present the data from Vietnam. And it's quite a number. So I think you can provide a very informative information. And my question is that, as we know, and in the published thousands of papers, we always know the advance of hepatoma improve the recurrence of survival. And after your analysis, what can we do? And how do you put the modifiable factor into analysis? It means that what we did can improve the survival. So, and if you want to continue your study, what will you do? Focus on this issue.
Yeah, I think about modifiable factors first. Just for the liver function before the operation, before the liver resection, we're not enrolled in this study because we still have in Children's Hospital right now. We still have the paper medical record, not the electronic one. So this is very hard to retrieve the past data, example for the liver function, for ANB APRI function. So when we do this research, this study, what we have is only the time when the patient 1 month at the time of operation and 1 month after follow-up, and later we follow up until the patient lost a follow-up or disease or something like that. But the liver function before that is not assessed, cannot be assessed. So I'm still working on it. Maybe we can identify some modifiable factors to improve that. And one of the most difficulties in our situation is that the incidence, the diagnosis of HCC in chronic hepatitis patient and also in untreated patient in Vietnam is also a problem, because all of the patient has come to my hospital with a advanced stage, such as large tumor or portal vein invasion, something like that. So the problem is not our study include. The problem is more open from the surveillance and early diagnosis and early detection of HCC in the high-risk patient. Thank you.
And since you have a large proportion of HPV-related patient, so I think the nuke therapy may be also an important factor.
Yeah, I think that.
So I have a question for you. First of all, congratulations for your nice talk, and I was so impressed to see your very well prepared presentation and well done analysis. And I have several questions. And the first one is that after resection, what is the percentage of patients who are followed at your hospital or center? Most of patients are followed at your hospital or referred. They came back to the physicians, general physicians.
All of the patient were follow up in my department. Yeah.
So what is the dropout rate?
The dropout rate in 1 month is 0 because every patient has to come back at least 1 month. And the dropout rate in this study, I calculate it's around less than 5%.
Most of them are, so most of them are hepatitis B patients. So
yes.
Most of them are treated by nucleotide and nucleotide analogs.
Yeah, most of them are treated by the TDF and.
That is a standard of care in Vietnam.
Yeah, this is standard care, and this is also covered by the insurance for HCC related, HPV related HCC. So,
so I think that most of patients are under nucleotide analog treatment, so there might not be room for improvement regarding the hepatitis treatment.
Yeah, but the insurance is covered for the TDF drug, but it's not covered for other tests to evaluate the antiviral treatment, such as HPV DNA or something like that. The insurance is not covered. And actually, a lot of patients in Vietnam is really not good in financial status. So it's also a problem here.
I have a question. Microphone? Oh, it's okay. Yeah, I will give you a microphone.
Hello. I also want to congratulate you on a very good presentation. A lot of my questions you answered at the end. But I wondered, it seemed like from your slide, only 2.1% of your patients have cirrhosis underlying,
Yeah.
right? So they should all have good liver function, right? Before you're, and I was also impressed by such large size that you do surgery on of patients. And my question for you is, you concluded that it's okay to do surgery, but when you look at your risk factors recurrence, it seemed like size and number were a problem. So I was curious about your conclusion. So you say bigger, more cancer, more likely to recur.
Yeah.
And the number of people you did surgery on with a lot of cancer was very high. Do you think that's the best treatment?
Yeah. I also think about that, but in a situation of our country where if the tumor is larger, maybe for example larger than 5 cm, it's really hard to do the ablation, or TACE is maybe unsuitable for that patient. But for the systemic therapy, this is not covered by insurance, and it costs a lot money for the patient. Just for the TKI, this is really among the cheapest systemic therapy, right? It costs more than 2 times salary of me. So it's really hard to perform the systemic therapy for such patients. So we don't have anything left, only surgery. But if the patient has we recognize the prognostic factors like that, if the patient has the condition like that, if the patient has the financial status enough, we may propose for the systemic therapy or something like that.
So the other question is, you mentioned that you could not check hepatitis B DNAs pre-surgery. You don't know how many people.
Yes, pre-treatment, also post-treatment.
And do you know most of the time that people come to see you, are they mostly treated?
Most of the time, they are not recognized that they are having hepatitis B.
Any comments or questions from the audience? So, did you register the treatment for recurrence in your database?
I'm sorry?
Recurrence treatment, for example, surgery or ablation or TSE for recurrent disease after resection.
Yeah, actually, this is the first study in our hospital, including the recurrent rates with a long-term follow-up. What we do first is with surgery, and then we will maybe in the future we will present the data of ablation in TAC or systemic therapy also. And I hope one day I can come here again to present it.
So good luck. Thank you.
Thank you so much.
Thank you. I'd like to move on to the next topic. Thank you very much. The third speaker in this session will be Yuri Ogasawara. She will be presenting the clinical features of MET ALD and ALD in patients with hepatocellular. Thank you.
My name is Yuri Ogasawara from Tokyo Women's Medical University Gastroenterology. Today, I would like to present a comparison of clinical features between metabolic dysfunction-associated steatoic liver disease, AASLD, and alcoholic-associated liver disease in patients with hepatocellular carcinoma. I have no disclosures. In 2023, a new concept of steatoic liver disease was proposed and classified into 5 categories. The diagnostic criteria for AASLD, metabolic dysfunction-associated steatoic liver disease, included fatty liver with at least one of the 5 cardiometabolic risk factors. MET ALD represented the intermediate drinker group, patients with AASLD with high weekly alcohol intake, and alcohol-associated liver disease, and others with fatty liver disease with identifiable specific cause and others of unknown cause. All-cause mortality was reported to increase in the patients with pure MASLD, MET-ALD, and ALD. The risk of decompensation was significantly higher in the ALD group compared to MASLD or MET-ALD, particularly in cases of advanced fibrosis. Alcohol use interacts with cardiometabolic risk factors and may impact the risk of decompensation. However, this relationship remains unclear. We utilize criteria based on the amount of alcohol consumed to classify the patients. Our aim was to make clear the clinical features of MET-ALD, which is a new proposal that was made in 2023. Therefore, we compared the clinical features of MET-ALD and alcohol-associated liver disease, ALD, in patients with hepatocellular carcinoma. First, we compared study 1. We compared clinical characteristics between MET-ALD HCC group and ALD HCC group. Then analyzed a retrospective cohort of the mortality rate, causes of death, and mortality risk factors. Next, study 2, we compared clinical characteristics between liver cirrhosis patients and chronic hepatitis patients of MET-ALD HCC group and ALD HCC group. Then analyzed a cohort of the mortality rate and causes of death. Furthermore, we evaluated the risk factors of mortality in liver cirrhosis and chronic hepatitis separately. Study 1, we compared clinical characteristics of the patients with MET-ALD HCC and ALD HCC. ALD HCC group showed older age. Hypertension and dyslipidemia were more seen in the MET-ALD HCC group. But HCC ALD patients had ALD HCC patients had more complication of diabetes. Also, cirrhosis was more seen in the ALD HCC group. Next, the laboratory data of the patients. ALD HCC group showed low albumin levels, low PT% levels, and high FIB-4 index levels, showing fibrosis. Also, the HCC group showed high GGT and blood sugar levels. For the survival rate, ALD HCC showed significantly low survival rate compared to patients with MET-ALD HCC. The most frequent cause of mortality was liver-related in both groups, but higher in the ALD HCC group. Also, the rate of infection was high and stood out in the cause of mortality in the MET-ALD HCC group. By multivariable analysis, independent predictors of overall survival in the MET-ALD HCC group were non-complication of dyslipidemia. In the ALD HCC group, by multivariable analysis, independent predictors of overall survival were older age, non-complication of hypertension, low albumin levels, and high FIB-4 index levels. In summary, until now, significant differences between the two groups were observed in age, prevalence of hypertension, dyslipidemia, diabetes, and cirrhosis. Also, albumin, GGT, fast blood glucose, and PT% FIB-4 index levels. The 5-year survival was significantly lower in the ALD HCC group. Among etiologies of death, the percent of infection was significantly higher in the MET-ALD HCC group. Also, risk factors for mortality were non-complication of dyslipidemia in the MET-ALD HCC group, and old age, non-complication of hypertension, low albumin levels, and high FIB-4 index levels in the ALD HCC group. Next, study 2. We compared MET-ALD and ALD stratified with liver fibrosis. First, the LC group. The characteristics of the patients, complication of diabetes were more seen in the ALD-HCC group. For the laboratory data showed low albumin levels, high FIB4 index markers, high AST and GGT, fast blood glucose sugar levels in the ALD-HCC group. The ALD-HCC group showed poor survival rate compared to the MET-ALD-HCC group in patients with LC. By multivariable analysis, independent predictors of overall survival in the LC group were low albumin levels and high FIB4 index levels. Next, we compare the chronic hepatitis group. MET-ALD-HCC patients had higher BMI, and for the laboratory data, high FIB4 index levels were shown in the MET-ALD-HCC group. There was no difference in the survival rate in the patients with chronic hepatitis. And as for the risk factors in multivariable analysis, there were none shown. Some summary, FIB4 index was higher in ALD-HCC patients in the LC group, but was higher in the MET-ALD-HCC group in the chronic hepatitis group. The survival rate was lower in ALD-HCC patients with liver cirrhosis, but there was no difference in the survival rate between patients in the chronic hepatitis group. Here are the results. MET-ALD-HCC patients were of old age, had more complication of hypertension and dyslipidemia, and the ALD-HCC patients had more complication of diabetes and experienced greater liver stiffness. Regarding mortality causes, liver-related issues were the primary cause in both groups, but higher in the ALD-HCC group. The rate of infection was also another high cause of mortality in the MET-ALD-HCC group. In conclusion, the MET-ALD-HCC group showed a better prognosis compared to the ALD-HCC group. However, attention is needed for a non-liver related event in the MET-ALD-HCC group. Thank you for your attention.
Thank you for your beautiful presentation, and I think also a well done study. This paper is open to discussion. Comments from the audience? I have one question. You showed that I was so impressed to see the 35% of MET-ALD patients die from other causes. What is the specific cause? Could you show me the breakdown of the 35% of cause of death? And I think that also they may have increased risk of malignancy of other than liver, but you accounted for the malignancy other than liver in the pie chart. So what is the remaining cause of this in 35%?
Oh, the other cause. The other causes included causes that we couldn't identify, like died at home without no anatomy, so we couldn't we couldn't reveal the cause of death, or and also there were patients that went to different hospitals, so we couldn't identify. Yes.
So maybe they are, a lower risk of having the recurrence or disease progression. So they left from your hospital. and followed by other physicians, right?
One that I think that is one reason, and other reasons are maybe that they couldn't keep coming to our hospitals, so they moved to a maybe closer hospital.
Some patients with alcoholic bowel disease stop drinking after diagnosis of HCC. We frequently observe such a phenomenon, such attitude. Do you catch the data regarding the abstinence after the diagnosis of HCC in alcoholic bowel disease?
Yeah, the alcoholic consumption of patients is very hard to pick up, and so that is one problem. Maybe we need to make clear who drinks or keeps drinking or stops drinking. It was hard to follow up.
But for example, you can check the gamma GT. So we sometimes observe the decline, rapid decline after the diagnosis, and in some patients it perfect, completely normalized.
Yes, that is, I think that is a good point. So we'll try to look at it that way.
In that population, I think that they live much longer compared to those who continue to drink too much alcohol. You have a question?
Yes, I was wondering, your patients all had HCC, and the difference between med-ALD and ALD patients. Do you think they're different in patients who don't have HCC? It seemed like many of the factors that you saw were something we might have expected.
I think they're similar, but we do need to discuss without the group of HCC, I think, because it will show a bigger picture of the, because HCC group is a kind of limited, very small group. So I would like to, from now on, try to research on that too.
Thank you for excellent presentation. I have a question. And which includes a patient who drank a lot in the past, but now quit, and met ALD or ALD or MASLD or no?
You categorize the population based on the current drinking or past drinking?
Oh, we only saw 1 point, so I think it will mean past drinking.
Thank you.
I have a question and a suggestion. The suggestion where maybe you can try to conduct a lifestyle modification program for both kind of patient. I think that remove the cause of HCC is most important. So you may ask your med-ALD patient to decrease their body weight. Maybe you ask the alcohol patient quit their alcohol and the evaluation that this is really help for the patients. And my question is that why the FIB-4 score is different in LOC and the non-LOC patient? Why the LOT group has a high FIB-4, but in the chronic hepatitis has a low FIB-4?
Thank you. That is another good point. I am thinking of the same question too, and I thought maybe because in the CH group, because of med-ALD, HCC patients have higher age that occurred, but because we expected the ALD HCC patients to have more high FIB-4 index markers. So my reason I thought was that of the age, but maybe there are different answers.
So you categorize the entire population by FIB-4 index or other, what kind of criteria do you use for categorizing LC, liver cirrhosis?
We categorized also clinically. like low platelet levels or having complication of esophageal varix or big spleen, big spleen.
Because that FIFO index is not informative in patient with heavy alcohol drinking, because that they may have a higher AST value with a lower ALT value. So you categorize the patient based on the clinical findings. You're right. Thank you. Any other comments? So thank you very much.
Thank you.
So we have 3 presentations, and we have a great break for 15 minutes. Thank you very much.
Thank you for your comments. Thank you. Thank you so much.
Our surgeon would say no. No way. That's amazing. And the other thing, I know last one was long, like 25 years ago, and they did not have hepatology. They don't have the field of hepatology. Do they have hepatology now? Because when I was there, we were trying to start the idea of hepatology because there was no interest in this field. That's great. Yeah, yeah. Because we did a set of, I think, 6 visiting professor sets to try to bring the idea of hepatology. We did these early career development things in 3 cities. And it didn't exist. Yeah, yeah, no, they didn't have, in the mountains, their hepatoma was also thought to be organic fertilizer or something. It's like some kind of toxin. Yeah, in the countryside, like, because the person that sent us is a philanthropist, he's a very giving person, and basically he said that in parts of the mountainous parts of Vietnam, there's probably toxins that were causing cancer. Yeah, that was interesting too. That was a little bit, I was surprised because when you said it was vaccine and you totally brought it up, and it wasn't. Yeah. That's a good point, yeah. They don't always, yeah, the data, yeah, the data is variable. It's so different, HCC is so different in all Asia. Treatment might be different. Yeah. So in the United States, it is a political issue for the veterans. You know, veterans, okay? So all the veterans are treated now, okay? But the rest of the United States are not. Because the veterans are completely treated. We have no more, the only people that we cannot treat are people who live under the bridge and we cannot find them. But it's such a political thing. So the VA is very successful, completely treated everybody. But the rest of the United States, they're now working on it. No, that's worldwide. Worldwide. Oh my goodness, yeah. I was surprised by the rate of mast cell. Yeah. Yeah, I think so. Yeah.
When you look at the prevalence incidence of cardiovascular disease among massive
Yeah.
that number is not high. So they die from liver disease. They have so also these characteristics are diverse.
The other thing that's interesting is, you know, overall the incidence, because Hep C got treated.
Hi. Thank you for coming.
To see you. Good to see you again.
Hi.
Hi.
I'm
Nice to
Grace.
meet you.
Nice to meet you.
So this is a workshop for young investigators. We have a lecture series in the morning, and we have a 10 minutes for discussion. So I would like to ask you to encourage Go yes, sorry for it's okay. You can refer to this kind of application. But it's okay. I know that you have
Should I move to here or just stay here? Okay, because they said it's okay.
It's APASL, and you can here QR code and search by Google APASL.
Okay. Yeah. Yeah. Okay. Okay, I will do my best.
Is Japan the treatment rate for Hep C all finished?
Orphans, almost orphans, in Greece, mp41.
That's great. So easy to treat, so. Yeah, amazing. I actually, we don't even, the doctors don't do the treatment, just let the nurse.
That's okay, because they're very modern.
There's nothing to do, yeah.
Compared to interferon.
Yeah, we just, I don't even remember now, I can't remember how to do it because there's so many years.
I have been involved in taking interferon.
Yeah, that, I remember.
Japanese old.
Yeah. That is very bad memory for most of us. I know. It's horrible, horrible. Just terrible. That I remember. We're doing, like I said, I was saying that the overall rate of HCC seems to be declining.
From 2010.
So you know exact science, right, is trying to do the biomarker. They stopped for a while because the rate was low, so it cost more to enroll people. And so now the VA is doing a study, abbreviated MR versus ultrasound. And so the multi-center trial, and they had to, their input is you have to have a before greater than 3.25. The worst part is the only people who qualify now are alcohol. It's a low platelet and high HC. Because everyone else is is an indeterminate war. Yeah. So, but it's interesting they chose that to try to, because the study would be very expensive. But now it's all alcoholics in our group, and I'm thinking this is going to be terrible because they're never compliant. That's surprising. I wonder why. They say during COVID it was a problem. COVID was a problem. Yeah. Oh yeah, because they ask you if you are over 18.
You made it! Oh, you just went it this morning, right? Thank you so much.
I did my best.
That's so wonderful. So it's a very smooth flight?
Yeah, smooth flight, and then I used the train, and
Oh,
then
the train!
taxi.
Oh, train is faster, in fact. Yeah, train is fast. Yeah, great. So we can start right on time, right?
Yes.
1, 2, 3.
Yeah, 3.
Yeah.
Is it on pages 30?
Yeah, very nice. Yeah. So because each can have 10 minutes presentation and 10 minutes for discussion.
Yes.
Yeah. So if you don't mind, I start the session.
Yeah,
I
yeah.
introduce both
Okay.
of us, then you can introduce the first speaker.
Okay,
And
yeah.
I do second, you do the first. Okay.
Okay.
Sure.
No problem.
That's great. Okay, dear friends and colleagues, welcome back. I'm sure that you have been enjoying this wonderful meeting so far. So I'm Grace Wong from the Chinese University of Hong Kong. This afternoon, I'm very honored to have my co-chair, Professor Zhongming Lee from the South Korea, the South National University. Professor Lee is a radiologist and I myself a hepatologist. So in this session, we are very delighted to have 3 outstanding presentations. So in this workshop, we would love to have more comments from the audience about the methodology, analysis, and so on. So for each presentation will be 10 minutes, and we will also have another 10 minutes for detailed discussion. So it's a very, I'm sure it will be a very fruitful session. So now may I pass the time to Professor Lee to introduce the first speaker?
So, good afternoon, everyone. The first speaker in this session will be Dr. Muhammad Bilal Saiful Haq. I hope my pronunciation is acceptable. His title today is Preoperative Inflammatory Biomarker Analysis as a Predictor toward Hepatocellular Carcinoma Survival. Okay, yes. Thank you.
Yes. Thank you. Yes, thank you. Good afternoon, Professor Wong and Professor Lee, and all of my colleagues. It's my honor to be able to present our paper in here with the title Preoperative Systemic Inflammatory Response Biomarker Analysis on Prediction Toward HCC Patient Survival. Yes, we have nothing to disclose this in the study. Yes. Yes, the primary liver cancer, which the most common is HCC, is the third leading cause of cancer-related death globally, according to World Health Organization. And according to the Room5 et al., HCC is predicted to rise in the near future, with a 55% projected increase in new cases of liver cancer per year between 2020 and also 2040. And the most common etiology is still a chronic hepatitis B infection. And also in Asia Pacific, the number is also high and increasing. Well, in our country, Indonesia, the burden of viral hepatitis is also high. The latest data is in 2020 and 13 show the hepatitis B prevalence is 7.1% or 18 million, which indicates moderate endemicity. No newer data than 2013 because lack of information for the general population, but it is belong to several factors, including inadequate disease surveillance, geographical barriers, and also limited testing facilities to detection of chronic hepatitis B and C, leading to a large population of people remaining undiagnosed. But we believe the number is still increasing. And also, but the widespread use of surgical and local regional therapies worldwide for early stage of HCC, it gives a significant advance in HCC treatment strategies, improve screening modalities, and new systemic treatment options that extend the survival. The treatment of choice for early stage HCC is surgery or resection. However, this surgery is not without its problem. It's in terms of post-operative morbidity and mortality. And also post-operative complication is not only the short-term consequence, but also the long-term consequence. It has also been shown to be associated with exacerbation, and also the magnitude of the stress response from the surgical injury can lead to alteration of immune function, and also which turn the cancer progression and recurrence. We performed the meta-analysis and systematic review with the PRISMA guideline. We conclude 61 studies with the search strategies. We serve from the PubMed, MBS, Cochrane, and also ProQuest. with the eligibility criteria, all of available retrospective studies that examine the development of sears or fever, and also there is complication associated with HCC resection surgery. We exclude fever progression, sears, and sepsis. And the outcome of the study was we analyzed the relationship between CRP, CAR, GPS, LCR, LMR, NLR, PLR, PNI, and sears event in HCC patient after the surgery. And also we analyzed the hazard ratio. This one baseline characteristic, and also for the CRP forest plot. From the figure showed that the studies had a significant heterogeneity, and there was a significant increase between the group that experienced that and those who were not, especially in the Caucasian race compared to the Asian. And also this one is a CRP to albumin ratio, which is from the figure showed that studies include the significant heterogeneity, and that was significant increase in CAR between the group that experienced that and or low overall survival and those who were not. And also from the GBS also show the significant, and with the hazard ratio is 1.5. And also for the LCR or lymphocyte to CRP ratio, it shows the significant result with the hazard ratio 1.5. And also with the LMR, also showed the significant with the P less than 0.001, and also hazard ratio 1.27. But in NLR also showed the same significant result. But in PLR or platelet to lymphocyte ratio, it's not show the significant result, which is 1.05. And from the PNI or prognostic nutritional index, it also showed the significant result, and also the hazard ratio is less than 1. For the discussion, this meta-analysis is from a 61 research paper, and also inflammatory markers we use as the prognostic tools in HCC, especially in resectable, which always doing the routine laboratory perioperative. And also, but nevertheless, this study hasn't answered the mechanism of malignancy leading to systemic elevation response. It's still unclear to that. The study also showed that CRP, CAR, GBS, LCR, LMR, and NLR had a notable increase in the population with a higher mortality rate than the others. And also CRP could be used as a prognostic tool, especially to estimate and predict mortality in HCC patients who undergone resection and also have the routine laboratory testing. And also the elevated CRP albumin ratio is roughly associated with a double increase in mortality risk, which is 1.92. And also in biomarker of GBS and modified GBS were used to predict the aggressiveness and prognosis of a tumor, especially in a wide range of malignant tumor. Thank you for, with the conclusion, there was a significant increase in CRP, CAR, GBS, LMR, and NLR in HCC patients between the group that experienced that and those who did not. Not a significant increase in PLR between the group. And also from the PNI, show the increase significantly in groups with a good overall survival. Thank you for the attention.
Great presentation. So this presentation is now open for discussion. Any questions or comments from the floor? Especially our expert panel from AASLD and APASL. Any comments or questions? Thank you.
Yeah, thank you for a great presentation. Question for you. Did you adjust for the type of surgery or the stage of HCC or size?
Yes, thank you, Doctor. Actually, in this meta-analysis, we add from all of resectable HCC, which we mean to include all of the early stage of HCC. So not only the size or nodule, but all of the early stage of HCC, which is resectable and undergoing the surgery. So the aim is to maximize the benefit of routine laboratory pre-operation. Thank you, Doctor.
I think there might be a different cutoff point for CRP in each study. Do you check the cutoff point?
Yes, Doctor. Yes, the CRP itself in this meta-analysis is not really significant in the result, but we do the subgroup analysis, and we found that the Caucasian population had the more susceptible to worse overall survival than the Asian people in this.
Thank you for your answer, but I'm asking you the cutoff point of CRP, like 0.03, 0.3 or 0.5 or such as such.
Yes, thank you, Doctor. We take the cut point of the CRP based on the quartile, and we found the number is between in 45 and above the 45, we conclude is the elevation of the CRP, Doctor.
I think you might add some summaries, right? Because you checked so many biomarkers. For the audience, you might, summarize in the table or something like that to show the number of articles you choose and the odds ratio with the confidence interval. So the audience can, grasp the entire result.
Yes. Yes, Doctor. Thank you. Because the aim of this study is to from the previous literature that say that the inflammatory biomarker is related, especially in malignancy and also in hepatocellular carcinoma. So we make the put all together and make the puzzle, and we give we make the conclusion out of it. Thank you.
Okay, I have one question and one another comment. My question is about the patient population heterogeneity. I mean, many papers regarding HCC survival are coming from Asia. So in your meta-analysis, how about the proportion of ethnic group?
Yes, Professor. Yes, indeed, in this study, it was a really high heterogeneity, and also in baseline characteristic is not really homogeneous. So we performed the subgroup analysis, and we found the unique fact that in some biomarker like CRP, the Asian population is better than Caucasian, and also we conclude that we can make the better out of the laboratory testing.
My comment is that I know you may have limited presentation time, so you omitted the limitation of your study in terms of discussion, but I recommend you to include your own study limitation as authors. That would be quite nice for the readers. And when you submit paper to any journal, that would be also necessary. I think, as you mentioned, that there is a huge heterogeneity in terms of patient population is one limitation. And then, as Dr. Tateishi mentioned, that there are many variations in terms of cutoff values of many inflammatory markers. So I'm not an expert of meta-analysis, but there is one method to solve that kind of problem, which is individual patient meta-analysis, individual participant data meta-analysis. That's one method to solve diversity in terms of cutoff values.
Yes, thank you, Professor. Yes, in this study, indeed, it's the heterogeneity is really high, and we should give the limitation in our study. So the objective, and we give the in every side of opinion. Thank you, Professor.
I would also like to briefly comment on your presentation skills. So first of all, congratulations. I think this is a very important topic. You have done a lot of work. You gathered the data from so many studies. It's a lot of work. I have the feeling that your presentation slides are in general very busy. Many information. And because of the time limit, sometimes you pass through the slide quickly without highlighting the key message for the audience. So I will advise you to, probably you can simplify the slides a little bit as well to bring up the key messages, especially for the results. You have many results. Yeah, you have many figures, and you use the title mainly about the markers, but not highlighting the features or the key message. So I would advise you to rearrange it a little bit, as well as to try to be a bit more selective. You don't have to put up everything in your slides. You just select some key things that you wish to deliver the message to the audience during a presentation. You can include more details in your full paper. Definitely you can. But if you have 10 minutes presentation, I guess you have to only deliver 2 to 3 key messages. As well, when you present the slide, I know the screen is a bit low, but try to make more eye contact with your audience that can make your delivery of message more effective. Okay, any other comments or questions? So if not, thank you so much for your wonderful work. And
thank you, Professor Wong, Professor Lee.
Great, let's move on to the second presentation of this session. May I invite Regina Da Demakulagan from the Philippines. Regina is going to deliver a presentation entitled Durvalumab and Tremelimumab, the strike versus the Durvalumab alone for unresectable HCC patients, a meta-analysis. Regina, please.
Sorry. So good afternoon, doctors. I'm Maria Regina de Maculangan, a first-year gastroenterology fellow from St. Luke's Medical Center Global City in Manila, Philippines. And I'm here to present my meta-analysis entitled Durvalumab plus Tremelimumab, or STRIDE versus Durvalumab monotherapy for patients with unresectable hepatocellular carcinoma. Again, good afternoon. For our disclosure, we have nothing to declare for this study. So, hepatocellular carcinoma is the leading cause of mortality in cirrhotic patients, which comprises 75 to 85% of liver cancer cases in our country. Most HCC patients require systemic therapy as a result of advanced disease at diagnosis. Unresectable HCC are those with liver tumors not eligible for resection therapy, given the extent of the disease, location of the tumors in the liver, and patients who are older than 75 years old. A tyrosine kinase, sorafenib, has been the only proven therapy for unresectable HCC for many years. However, atezolizumab and bevacizumab outperform sorafenib in terms of survival. Recently, durvalumab has gained popularity for patients with unresectable HCC versus the first two due to its safety profile. So for the significance of this study, several meta-analyses have compared the efficacy of STRIDE and sorafenib with the Himalaya trial, but none of them compared STRIDE to durvalumab alone. This meta-analysis aims to compare STRIDE and durvalumab monotherapy in significantly improving overall survival and if the risks and costs of tremelimumab are beneficial to our patients. So the combination of durvalumab for programmed cell death or the programmed cell death ligand 1 inhibitor and tremelimumab or the cytotoxic T lymphocyte associated antigen 4 inhibitor known as STRIDE infusion regimen or the single tremelimumab regular interval durvalumab have shown additive anti-tumor activity and immunostimulatory effects. Durvalumab increases T cell activation and enhances the detection and ablation of the tumor cells, while tremelimumab promotes CD20-mediated co-stimulatory signal, leading to increased T cell activation. So for the methods, major electronic databases and gray literature searches were searched up to June 2022 for randomized controlled trials assessing the effectiveness of STRIDE versus durvalumab monotherapy in unresectable HCC patients. This study included 2 randomized clinical trials and Revman 5.4 was used to compute. Inclusion criteria were as follows. Studies comparing the efficacy of STRIDE compared to durvalumab alone in unresectable HCC patients. Second, the study population comprised adult patients more than 18 years old with histologically or radiologically confirmed HCC. And third, the value of odds ratio with 95% confidence intervals were reported. And the exclusion criteria were as follows. Studies included patients with resectable HCC who had prior systemic therapy or patients with portal vein thrombosis. And second, papers that were letters, commentaries, and duplicate publications. So this figure shows the flow diagram of this search study. Initially, 91 articles were identified through database searching and 87 of them were excluded. Most are duplicates and unrelevant studies. 4 articles were then assessed for eligibility, but 2 articles involved a different outcome, which is the pharmacokinetics and pharmacodynamics of durvalumab and STRIDE. So in the end, only 2 randomized controlled trials were then included in this meta-analysis. 2 studies are included in this meta-analysis, namely tremelimumab plus durvalumab in unresectable HCC by Abu Alpha et al. And the second is the safety, efficacy, and pharmacodynamics of tremelimumab versus plus durvalumab for patients with unresectable HCC, a randomized expansion of a phase 1 and 2 study by Kelly et al. The 2 studies included were published in 2021 to 2022, involving 1,503 patients in total and were conducted in USA. These 2 randomized controlled trials have a similar outcome. This table summarizes the risk of bias assessment for the included studies. Both RCTs were of high quality with a JADED score of 6. The JADED scale is used to assess a quality of a study. So for the results, the mortality rates between STRIDE and durvalumab monotherapy were compared. Resulting I2 of 0% implies that heterogeneity does not exist. Noted initially while eyeballing, there were more negative events in the durvalumab monotherapy group compared to the STRIDE group, which explains how both studies included in this meta-analysis favor the latter. However, the pooled odds ratio is 0.8, closely abutting to the line of no effect. This may be because of the effect of the first study with a bigger population size and its confidence interval line intersects the line of no effect. So the forest plot also shows that the diamond market intersects the y-axis, showing that there is no significant difference between the 2 groups. STRIDE has shown additive anti-tumor activity associated with complementary immunostimulatory effects. The addition of a single dose of tremelimumab is sufficient to add clinical activity to durvalumab. However, STRIDE has several adverse events compared to durvalumab alone, such as pneumonitis, nephritis, pancreatitis, diarrhea, dermatitis, and elevation in liver enzymes or bilirubins. The availability of tremelimumab in the Philippines limits its use. Results state that even with durvalumab alone, the mortality rate has no significant difference with unresectable HCC patients. The discretion to risk having more side effects with STRIDE and the cost of tremelimumab is upon the discretion of the physician with the consent of the patient. Since STRIDE and durvalumab monotherapy are relatively new regimens, it may be prudent to include newer studies who are currently in the works during this time. And a sensitivity analysis for the different adverse events of STRIDE and durvalumab could also be done in this study. So in conclusion, the addition of tremelimumab in STRIDE has no significant difference in the mortality rates compared to durvalumab alone. The additional costs and risks of STRIDE is upon the discretion of the physician and the patient. And here are my references. Thank you.
Thank you so much for a wonderful presentation. Now this abstract is open for discussion. Any comment or questions? Okay, may I invite the panel members to give comments? Thank you.
Congratulations for your nice study. I was wondering, you might be able to include the Himalaya study by retrieving the data from the figures or supplementary tables. When you add the result of Himalaya, the combined result might be statistically significant, right?
Okay. Noted that suggestion po. Thank you, Doc.
So, once again, congratulations on your excellent presentation. But I am wondering whether 2 studies are sufficient number for doing meta-analysis. From my basic understanding, usually around 10 papers would be ideal as a minimum requirement number of articles. And of course, theoretically, 2 studies can be possible for meta-analysis. But in your 2 studies, one study is only around 57, the other is more than 200. So probably conclusion may follow the first study having larger number. So I think that would be a potential limitation of your study. So when you write a paper, you need to include that as a limitation. And also another way would be you can wait a few more months until you have more new papers regarding this topic.
Yes,
that's my comment.
Thank you. So as I stated in my limitations, it's a relatively new study because durvalumab has gained popularity just now. So there are a lot of trials ongoing now. So I will include the next studies in the future. Thank you so much, po.
Yes, please.
Thank you for excellent presentation. I have a question. In my facility, and many patients can't continue the durvalumab and tremelimumab because of the early occurs adverse event. So how about your facility?
Currently in our country, in the Philippines, durvalumab has gained popularity because patients who undergo atezolizumab and bevacizumab have risk of bleeding, but with durvalumab, it is much lesser. So it's beginning to, the consultants, the gastroenterologists in our country are beginning to shift in durvalumab therapy. And so far, it has good outcome. Thank you.
First of all, again, congratulations for your wonderful study and presentation. I think your presentation is very nice. I like your slides because you can bring up the key message, which is very good. May I know whether you have other plans to make make another meta-analysis with a broader term, because now you're very focused or very niche to just particular new drugs, which I'm sure that more study will be coming up. But now around there would be so many different HCC systemic therapies, or just focus on immunotherapy regimens. There were still quite a few. Will you think that it is possible to include more immunotherapy regimens, that hopefully you can include more studies as well in your analysis? You can also have like different angles, for example, different subgroup analysis and so on. Do you have plans for that?
Yes, definitely in the future, we can include other immunotherapies like the Himalaya trial, who included the sorafenib, atezolizumab, bevacizumab, and the durvalumab and stride. So it's definitely one in the works in the future. Thank you.
I come up with a paper regarding the network meta-analysis, comparing the two or three, more than two, the systemic therapies for advanced advanced hepatocellular carcinoma. Are you interested in that kind of method?
Yes, definitely. I'm interested. I'll look up your study though.
Great. If no more questions, once again, thank you so much for your wonderful presentation. Congratulations. Okay, now may I invite the third speaker of this session, Mr. Yoshimi Yukawamoto. The presentation title is Safety and Efficacy of Microwave Ablation to HCC. Okay, thank you.
Hello, everyone. Welcome to Japan. I'm Yoshimi Muto from Osaka, Japan. Today, I'd like to talk to you about the safety and efficacy of microwave ablation to HCC. We have nothing to disclose for this study. I'd like to share the etiology and HCC surveillance in Japan. In countries belong to APASL, HBV, hepatitis virus B, is common, but in Japan, HCV is most common etiology. And in patients with cirrhosis, we screen for HCC every 3 or 4 months. And it is the same for patients with sustained virological response. So we can find small HCC. And it's BCLC cancer, BCLC staging system, so everyone knows well. And these two indicate ablation. And the decision to perform ablation depends on whether liver transplantation is possible. I show this chart. It's about the number of liver transplantation in Japan and in the USA in 2021. There is a big difference. And in Japan, the deceased donor is very few, and the number of liver transplantation itself is less than 1/20th than of that in the USA. So you may not know that, and it is very difficult to select the liver transplantation for HCC patient in Japan. So I show the Japanese guideline for HCC treatment in 2021. And the patient has good liver function and no extrahepatic spread and no portal invasion. And the tumor, the number of tumor is under the 3, and the largest diameter is under 3 centimeters. We consider the ablation or resection. I show the result of SAF trial. In this morning, Dr. Tateishi introduced this result, and he said it was very tough work. And thank you for tough work. So we can choose both resection and ablation for small HCC. And because the median recurrence-free survival didn't differ significantly, so we can choose both. And it is about the financial data. The radiofrequency ablation has been mainstay, but microwave ablation has increased in the recent years. Background and aim, we studied using microwave ablation in December 29th, and its use is increasing. So the aim of this study is to review the safety and efficacy of microwave ablation in our department. It's a method. 43 patients and 47 tumors were registered, and I focus on fifth point. First, frequency of sedation use and complications. Second, complications from microwave ablation treatment. And third, effectiveness determination after treatment. And fourth, local recurrence. And fifth, complication, a comparison with nodules treated with radiofrequency ablation in the same period. This table shows the patient and the tumor characteristics. And the median age is 75 years old, and 60% is male patient. And the most common etiology is HCV. And the average tumor diameter is 18.9 millimeters. And the most HCC locate right lobe and intrahepatic areas. And we use artificial ascites or contrast-enhanced ultrasonography for some patients. It's the first result on frequency of sedation use and complications. We use sedation for 21 patients, and we use midazolam, and the average dose is 1.9 milligram. There were no complications from the use of sedation. When one patient had very severe complications, and she was 70 years old, and she has medical history of diabetes. And 2 months after treatment, a liver abscess was developed in the same treated area. And we performed surgical drainage for her. And after ablation therapy, we checked the enhanced CT to check the ablation area. And 2 HCC remained after treatment. In this case, the HCC located the subcapsular. And in this case, the patient had ascites. It is a reason why the treatment was difficult, I think. And next, I show the local recurrence of microwave ablation treatment. Local recurrence occurred in 8 patients, and the local recurrence rate is 10.9 of 1 year and 31.3 of 2 years. And we consider why the local recurrence occurred. So we check the location or the presence of artificial ascites or enhanced ultrasonography and so on, but we couldn't find the reasons of local recurrence. And it's a last data. So we compare the microwave ablation with radiofrequency ablation during the same period. And the diameter, tumor's diameter of microwave ablation group is significantly larger than that of radiofrequency ablation group, but the local recurrence is no difference. In conclusion, there were no complications from the use of sedation and only one case of complication associated with ablation, suggesting that safety is ensured. At the time of analysis, factors associated with local recurrence couldn't be identified, and further follow-up and investigation are needed. And compared to radiofrequency ablation, there was no difference in treatment efficacy even in tumor with larger diameters. Thank you for attention.
Thank you very much for a wonderful presentation. Now it's open for question. Yes, Mieta.
Thank you.
Is the RFA microwave, was there a particular reason to choose one versus the other one during that period?
Thank you for your question. Recently, we often use microwave ablation, but so some doctors said it is difficult to puncture using the microwave antenna because it is thicker than RFA needles. So it is difficult to puncture the deep the internal the tumors. So sometimes we use for the RFA.
I have a question for you. First of all, congratulations on your excellent presentation.
Thank you.
But regarding your presentation, you are dealing with a little bit of a technical aspect of treatment. So in your presentation, I recommend you to include some basic information about the microwave system and device.
Okay.
Because there are many microwave systems and different antennas. So depending on which system you use, you may have different results. It's similar to RFA. So in both RFA and microwave, you need to include such kind of information. And as our panelist mentioned, if there is a certain preference of operators who do both techniques, one technique over the other technique in certain indication, maybe it creates some bias. When I do the ablation, if the lesion is located in the hepatic dome or segment 7, I need to use artificial ascites or pleural effusion. And then the microwave antenna is 13 gauge. RF electrode is usually 17 gauge. And the shaft strength is a little bit softer with the antenna, microwave antenna. So sometimes the lever displaced by the antenna when we try to place antenna into the lesion. So that means when the lesion is located in a little bit tricky location, operator might have a preference to the RF ablation rather than microwave ablation. So that would be a certain bias. So when you write paper, probably you need to include the information about tumor location and also the operators of doing ablation technique in your institute. There should be no difference in terms of operators who do the both techniques.
Thank you for that important ideas.
May I? Yes, please. Yeah, thank you.
I'm Song Wei from Vietnam. So thank you for your nice presentation. But I think that one of there are some advantages of microwave comparing with RFA is that the microwave can use for the bigger tumor, maybe up to 5 cm, and also with a shorter ablating time. And another thing is the hedging effect. So hedging effect will reduce the effect of the RFA, but microwave maybe we don't care much about the hedging effect. But in your presentation, nearly all of your tumor is less than 3 cm. Are you any data about the bigger size, also about the ablating time? Thank you.
Thank you.
May I also ask about the tumor location? Because I can see that you have 43 patients, but 47 lesions, which means some patients may have more than one lesion. Is there any minimum distance that between the two lesions you can do microwave to both? Or do you worry about the ablation area will be too large?
Yeah, we performed thank you for that question. And we performed 2 times separately. Yeah.
Yeah.
Thank you.
Okay. Yes, please. Yeah, thank you.
Thank you. Congratulations for your nice talk, nice presentation. And John Mealy and I'm expert in this field, and as you know, and it seems like the local recurrence rate is might be very high. Yeah, it is more than 30% in 2 years or 3 years.
Yeah.
I'd like to know the definition of local tumor progression on your in your institution.
Yeah, I have the response because, about the local recurrence. So in our facility is university, so we need to train the young doctors. But your facility is also, but then so sometimes young doctor perform the ablation. So I think it influence on the local recurrence. So we need to improve and keep the treatment levels. And it's our problem.
As you attended in the morning session, you learned the biases, and that is a kind of bias. And maybe the young trainee prefer to use radiofrequency ablation, and maybe the expert physicians may prefer to use microwave ablation because they are so experienced. And because this is a scientific session, you need to make your study and result more scientific based on the, you need to understand what the biases is, and you need to stratify, for example, the experience of the operators, or you need to, match the size of the nodule or the locations of the nodule between the two modalities. Then you can show the reproducibility of your result, unless that is only personal information or personal experience.
Yeah, thank you for your advice. Yeah.
So one way to make a good defense for your relatively high local recurrence rate would be providing or analyzing the data regarding tumor morphology. So we all know that even if tumor size is the same, multinodular confluent type has a much higher prevalence of microsatellite and also microvascular invasion compared with single nodular type HCC. Your mean tumor size is 2 centimeters. So probably many readers expect maybe 5% 1 year local recurrence rate and around 10 to 12% 2 year local recurrence rate. That would be the current result at many centers. So if you just say we have a variation in our operator, so that provides dismerit on your paper. So you need to check biological aggressiveness of your target tumors. Even if tumors are small, if your target tumors have much worse biological aggressiveness than other papers, probably you can make good defense.
Oh, okay. Thank you for your advice. Yeah.
Great. Yeah, wonderful. Yeah, I think all the comments, questions can further improve the study design, the paper, as well as your presentation skills. So once again, thank you so much for your active participation and the wonderful presentations. So may I invite the 3 speakers and the 2 panel members to come out to take a group photos? Yeah, thank you. Yes, and the 2 previous presenters too? Yeah. Yeah. Thank you. So Great presentation. Thank you so much. Yeah, wonderful program. Thank you. Thank you so much, Mother. Thank you so much. I will send you my photos. Yeah, thank you. Thank you so much. Thank you.
学长了。
This is very nice, actually. Yes, he has organized. Yes. Are you, is that in Tokyo? Yeah. Come down. Kyoto.
いや、わかんないです。ないことがある。あるんでしたっけ。いや、でも先生。でもあれですよね、前のセッションとかね、前のセッションも出られて、ポストグラジュエートにも名前があって。 every 5 minutes.
Mm.
あとちょっと間違ってたんで、さっき電話して1日ちょっとずらして、もともと金曜日は別に。土曜日も、はい、司会。日曜日。今つながってもないんで、一応前もってつながってない。なんかお伝えはしてるんですよ。 I understand. We have a special team for any kind of in our hospital. Okay. Not hematologists and allergic doctors, also lung doctors, to take care of patients.
I don't think that oncologists are, I don't think they're very good with chemotherapy side effects because they're so trained in all different types of chemotherapy, right? So they don't follow even their own guidelines. And when they get colitis, they don't follow the guidelines. They just always give 80 milligrams no matter what stage, what level, what grade. So patients get a lot of steroids.
Our IBS.
Our oncologists just give you They call everything colitis, but it's not colitis, yeah.
Nice to meet you. So our session is starting 20, but because I see two different schedules. Yeah, I have another chair, so just finish. Yeah. Okay, so we have
we can't connect to
oh, sure. So,
first presenter.
oh, okay, yeah. So you will chair the first. Yeah, okay.
And
Second
presenter,
I can check.
Online.
Oh, I see, okay. So you will chair the first one. Okay, yeah. So please, yeah. So there are two. Oh, three. Okay, yeah. So the second will be online. Oh, the second, okay, I see.
First presenter may be absent.
Oh, first one is absent.
Maybe.
Oh. Two speakers did not come. Oh, so. So later you will, so this first one did not come. So we will start at second or?
We're waiting for the second speaker.
Second speaker. Okay, yeah. I see, yeah. Yeah. Wait for 5 minutes. Okay, yeah. Sure. Okay, it's okay. Yeah. Then I'll go to restroom. Yeah. So, toilet. Yeah. So if study, please. Yeah. Thank you. Thank you.
What is the algorithm? I have not really have to speak. Only 10 days ago. So I'm not sure about that, you need to explain and we have to talk about shift from academic to research. And or actually look at the number.
Yeah, so Ray does not want to give the talk. So he asked me this morning.
This morning? That is quite ordinary in PTSD.
So I'm like, okay, what am I supposed to talk about?
I'm so sorry. But I'm not organizing this session.
Because, you know, I know it's okay. I just was wondering what we were going to talk about. Our patients have very bad access to treatment. Most many people live in the countryside. There's nobody.
Yeah, you need to come
Our patients, they live too far away, so they get taken care of whatever local they have, and it's not very good.
So I'm afraid we need to skip 2 presentations.
Oh, so direct proceed to the third one. Yeah, okay, yeah.
So,
So the third one is here.
Yeah, good afternoon, everyone. Welcome to this session. Sorry to keep you waiting. I'm Yoshinari Asaoka. I co-chair with Professor Chunjen Lee. Unfortunately, first speaker may be absent, and second presenter will attend online, but now we can't connect him. So could you start with third presenter, please? Third presenter is Dr. Novi Rahayu Arianti from Indonesia. Are you ready?
Thank you.
Please start.
Yeah. Good afternoon, Prof, Brother, and all colleagues. Konnichiwa, Assalamualaikum warahmatullahi wabarakatuh. First of all, it is my honors, and I want to thank you to Dr. and Prof for giving me privilege to present our simple study in Surabaya with the title of the randomized control trial, reduction of bilirubin after steroid for biliary atresia. And we declare that we have nothing to conflict of interest. Introduction, biliary atresia remains a global public health problem with the reported incidence ranging from 5 to 32 cases per 100,000 live births in different parts of the world. PA children with delayed diagnosis or failed hepatic portoenterostomy generally develop several complications of end-stage liver disease, requiring both emergency and long-term management, utilizing public health care resources, and having financial burdens to the public health system. Although COSAT therapy has been established for a long time, the need for liver transplantation is still high. But unfortunately, the liver transplantation is not available in all countries. And the pathogenesis of autoimmunity in development of biliary atresia, obliterative fibrosis is currently widely discussed. So we have the method of our study. This method is randomized control trials on infants aged 2 weeks until 3 months with biliary atresia at the Sutomo General Academic Hospital, Surabaya. The subject were grouped into 2 groups, methylprednisolone and placebo. And the methylprednisolone was given at a dose of 2 milligrams per kilogram body weight per day for 14 days, and bilirubin level were assessed before and after treatment. Data analysis was performed with SPSS. And the diagnosis criteria from this patient, jaundice and alcoholic stool, increase of direct and total bilirubin, and then the 2-phase abdominal USG reveal gallbladder contractility perturbation is including absent or atretic gallbladder. And then we started a liver biopsy. The histology finding reveal extrahepatic cholestasis with the portal and periportal fibrosis or bile ductal proliferation. And the result of our study, this is the basic characteristic of subject. The characteristic of age for MP group was 9 weeks, and the placebo was 10 weeks. And we see that the p-value is 0.354, and then the basic characteristic of the gender, the male is 13 for the placebo group, and the 9 in the MP group is 13, and then placebo group is 9 male. And then the onset jaundice was less than 2 weeks. In the methylprednisolone and the placebo is the same 11 weeks. And then the alcoholic stool, 14 babies, and the placebo 14 babies. And the dark urine, we saw that the MP group with 7 babies, and the placebo is 4 babies. For all these basic characteristics, there is no difference, significant difference for the p-value. So this is not confounding. I think this is not confounding factors. Then this is the table 2, the clinical radiology and histology findings. That the hepatomegaly is found that 17 babies in the methylprednisolone group and the 17 babies in the placebo with hepatomegaly. And then the splenomegaly, we found that the babies in the methylprednisolone with 3 baby with the splenomegaly, and the placebo, we have the 9 babies with the splenomegaly. And then we had the portal hypertension, the same babies, 6 babies in the MP group and the 6 baby in the placebo group. In this VHC finding, we found that all the babies with the perturbation of the contractility of the gallbladder. And the liver biopsy, all the babies, 14 babies, it revealed that periportal and portal fibrosis and the ductular and bile ductular proliferation. From this clinical radiology and histology finding, we found that the p-value is not significant differences, but on the splenomegaly, this is 0.038. We reveal that this is the difference significant for the MP group and the placebo group. For the basic bilirubin profile, before the treatment, we saw that the bilirubin, direct bilirubin in the group of methylprednisolone in 6.99, and then the placebo 6.60x, and the bilirubin total in the MP group 9.87, and the placebo group 9.44, and then we have the bilirubin direct and total 0.74. This is the all of this basic bilirubin profile. The p-value is not with the difference, is not significant differences. We using man-Whitney test with significant less than 0.05. In the table 4, we saw that the bilirubin pre and post methylprednisolone, we saw that the group of methylprednisolone with bilirubin direct pre-treatment is 6.9, and then the post-treatment is 2.0 with the p-value 0.00, and the placebo group 6.68 for treatment, and then the post-treatment 5.228, and then the p-value is 0.02, and then the bilirubin, total bilirubin with the group of methylprednisolone 9.87 with the post-treatment, and after we gave methylprednisolone decreased 3.35 with the p-value 0.0. And then in the placebo group with total bilirubin is 9.44, and then the post-treatment until after we have the methylprednisolone, bilirubin decreased 7.05 with the p-value 0.003. But unfortunately, the direct total bilirubin were not significant. We use this Wilcoxon test to analyze this study with the significant less than 0.05. So this is the bilirubin difference pre and post methylprednisolone. We use independent t-tests with the differences from the methylprednisolone group bilirubin direct 3.88 and the placebo 1.4, and then the total bilirubin 4.45 and the placebo 2.39. We have the p-value for all of bilirubin direct and bilirubin total with the significant difference, with the p-value 0.002 for the bilirubin direct and 0.03 for the total bilirubin. Discussion. Various immune mechanisms have been proposed, including immune dysregulation, autoimmunity, and susceptibility of the neonates' immature immune system, while the precise interplay between these processes has not been fully established. Extensive research in this field has identified key components of the innate and adaptive immune response in both the early and late stages of PA. Theoretical benefit of using steroids include improving biliary inflammation to promote cholerasis. However, their benefit in PA remains unclear. And Davenport studied the effect of oral prednisolone after KPA and found that while there was improvement in jaundice in the early postoperative period, particularly for infants less than 70 days old, but there was no significant reduction in the need for liver transplantation. The utility of steroid was most extensively examined in the multicenter double-blind steroid in biliary atresia randomized trial, in which infants receive a 13-week course of either high-dose steroid or placebo starting within 72 hours after Kasai portoenterostomy. Results from START show not differences in total bilirubin at 6 months post-KPA or 2 years survival with native liver in those that receive steroids. And furthermore, the treatment group experienced impaired growth and a shorter time to first serious adverse event. Our conclusion for this study, pretreatment bilirubin level were not significantly different between the methylprednisolone and placebo groups, and bilirubin reduction was significantly greater with methylprednisolone than with placebo. And maybe we can use methylprednisolone before hepatic portoenterostomy could be benefit for children with biliary atresia. Thank you. Arigatou gozaimasu.
Thank you for a nice study. I would like to make sure that this study is ongoing for longer prognosis or result. For example, survival or transplantation.
Yeah, this baby come to us with jaundice, alcohol, and direct bilirubin and total bilirubin increase. And we have these babies examined for liver biopsy and USG and reveal that biliary atresia, Prof. And then during waiting for the calcium portoenterostomy, we give the methylprednisolone, Prof. We give the methylprednisolone, and we study that 2 weeks. We given the methylprednisolone 2 weeks, and we study that there is the significant decrease for the bilirubin direct between placebo and methylprednisolone group. The study from methylprednisolone for before KPA is masih belum ada, is null. Jadi belum. There is nothing. There is no study given MP before KPA.
Thank you. Are there any comments or questions?
Congratulations on a nice presentation.
Thank you.
So, did you undergo a randomization process?
Yes.
I wondered if you could explain the randomization process.
The randomization process we had by number. Just by number, we accept this baby in the polyclinic. Then we at the number one is MP, and number 2 is placebo. Number 3 is MP. Number 4 is placebo randomization. We use this number,
But not blinded.
we're not blinded. Yeah. We're not blinded.
Other question, I noticed that the dark urine
Yeah.
was more in one than the other, but not significant. It seems
significant.
interesting that the numbers look pretty different.
Yeah, I think. Sorry. Okay. Yeah, in the MP group, we found that the dark urine 7 babies and the placebo 4 babies, but this is with p-value 1.0. There's no significant differences, Doc.
Yeah.
Yeah.
And also, how did you assess splenomegaly?
We assess, we don't do the cholangiography, Prof, because this is we had a long row, antrian apa ya, long row. We had a long time to wait this patient to go to the digestive operation to run the cholangiography, then open cholangiography, and then Kasai. So we don't use the cholangiography to for the criteria diagnostic criteria atresia biliar, Prof.
Interesting. I ask because there's, radiologically, it's actually difficult to determine splenomegaly. There's no good defined methodology for determining splenomegaly. And it sounds like you use cholangiography.
We use liver biopsy and USG, Prof. And we found that the liver biopsy revealed the extrahepatal cholestasis, Prof, that they reveal the portal fibrosis, periportal fibrosis, and proliferation of bile duct. And then the USG is the reveal absent or crescentic the gallbladder. Prof.
Yeah, no, I only asked because splenomegaly is actually not well defined.
Okay.
Congratulations for your nice study. And I have several questions. And the first, do you know the consult guideline for randomized control trial? So you need to follow that guideline if you want to publish the paper in a quality journal. And you need to show the patient flow diagram. And, you need to, show the potential number of enrolled patients. Then you select the patients to randomization. And did you set the primary endpoint regarding the effect of prednisone for this population?
Pardon me, bro?
Primary endpoint. You performed 3 statistical analysis for those population, pre and post, and
post.
Yeah.
Primary, bro.
Yeah,
Yep.
because this causes a multiple comparison problem. So you need to set the pre-specified outcome measure before statistical analysis. Then you can apply the p-value of 0.05 for the primary endpoint. And I think as Dr. Asaoka asked that we need a final outcome, and because most of them were followed at this moment.
At this moment,
And they
still
almost
follow.
all of them are survived.
And some of them already had the KPA, Prof. Some of them already KPA, and we still follow 14 babies for this study. Prof.
Thank you.
Yeah, actually, congratulations. This is a very important study in the pediatric population. So all patients are scheduled and waiting for Kasai.
Yeah.
And this study purpose is mainly to assess the effect of the methylprednisolone on the reduction of bilirubin, either total or direct. So the main question will come, what's your expected benefit of reduction of the total bilirubin on the outcome, including the waiting time for Kasai procedure or other clinical outcome? If the children indeed achieve reduction of the bilirubin, what benefit do you expect for them to obtain?
Our primary goal, Prof, we want to, maybe methylprednisolone is the one of our solving problem for the atresia biliary, because in Indonesia, liver transplantation is so much expensive, Prof. So expensive, so we can do this for our baby. And besides that, our assurance, national insurance assurance, is not full covered for atresia biliary to transplantation or for KPA, Prof. So we had just one hope, maybe in the future methylprednisolone with the precise dose, with the precise time and precise onset to give the methylprednisolone. It is our problem solving for atresia biliary, Prof.
Yeah, so maybe you can consider if the baby had a reduction of total bilirubin, maybe they have a longer survival time or longer waiting time or other clinical benefit, then that would be beneficial for the children population in your country. I think that's very important. Yeah. And I see some children develop jaundice within 2 weeks or after 2 weeks. So will the timing of the onset of jaundice influence the response to treatment or influence other clinical outcome?
This is in our study, we get the methylprednisolone before 12 weeks, Prof. So we give the placebo, we give the methylprednisolone placebo for the baby with the age under three months, Prof. So if the babies come in the age of 2 months old, so we can give them the methylprednisolone for 2 weeks, and then with the KPA, so we can use the methylprednisolone first, and then we assess this bilirubin.
Yeah, why I ask that's because if the onset of jaundice influence the outcome, maybe we can take this factor into account and stratify before randomization according to the onset of jaundice. I don't know, but that will depend on your expertise whether the onset will influence the outcome. If yes, maybe you can consider taking the onset time as a stratification factor before randomization.
Thank you, Prof. This is in our study. The onset of jaundice is we differ for 2 weeks, less than 2 weeks, and more than 2 weeks, Prof. But in this study, the p-value is with no significant differences, Prof.
Yeah.
From the less or more than 2 weeks, there is no significant differences, Prof.
Okay.
The onset of jaundice.
And how many cases you expect should be recruited to obtain the significance of your study? Is there any statistical estimation? I think it's difficult because the case is not so many.
Yeah.
But for any study you may consider, how many cases will be needed?
For the sample, this is we just only have 15 for MP group and placebo 15 for placebo group, Prof. We use the sample size, rumus ya. Sample size to count how many for this sample for this study, Prof. And we found that 15 MP and 15 group. So I think the 20 for MP and 20 for placebo, this is a good enough, Prof.
Yeah, okay, you can consider, think about it, because you have current some data regarding the outcome benefit by using methylprednisolone. So maybe you can consider about the case number suitable for this study. And finally, you suggest the benefit effect of methylprednisolone is through some immune modification. So is it possible to do some PBMC study clarifying the impact of the immune profile change on the reduction of the total bilirubin?
We already had for the marker immunology, Prof, immunology marker, but we have the assurance national assurance itu not cover all the marker immunology, Prof. So we have the problem of the funding, Prof. I think it's the big problem from us for us.
Okay, yeah, thank you. So is there any question from the floor for Novi? So overall, I think this is a very wonderful job, and congratulations for your good result, and hope the opinion, some suggestion may be beneficial for your future work or your studies. Okay?
Thank you, Prof. Arigato.
Thank you.
Unfortunately, second presenter is also absent. So we would like to close this session. Thank you for your cooperation.
Thank you. Thank you. Thank you. Thank you. Yeah, you are a judge. Okay, that's it. Yeah. Thank you.
she's been wanting this account for a while. Yeah. And now they research, so it's all internal candidates. So there'll be 5 candidates, and they probably will take 5. But Elliot is like, wow. He's very energetic. He's very energetic. The problem with Elliot is that he doesn't understand that everybody else does not have the same goal that he has. You know? Yeah. Yeah, he does. He's unbelievable. He's a good father too. It's like, he just has so much energy. It's crazy, right? And then I'm having him run tumor board a little bit because he was so difficult because when he wasn't going to tumor board, he don't like their decision. So then you make him run tumor board, then he's fine. Because you know how sometimes if you're not there at tumor board, you may not agree because you weren't in the discussion with the patient. So he's very, very caring about his patients. Very dedicated. Which is not always the case, you know, in the United States, professors, they don't always work around the patient. It's hard to find someone who actually gives his patient the cell phone. I said, Elliot, I don't think that's a good idea. No, he does. He answers. I hear him all the time. But you know, it's like, Elliot. Yeah, he does. He does. And he shouldn't, but he does. But the problem is that he doesn't always write everything down because if you're answering with phone, you're not putting it. You know, in the medical record, it's usually like a secure message, and technically, it's not a good idea. Because usually you're supposed to do it through the proper secure message. You know, we have nurses, they go through the nurses.
We don't have a special
Exactly. We do, but he won't use it. He uses stuff. We do, and in fact, that's the thing. But it's because he's a good doctor, right? But the problem is that, yeah, we have a secure doctor. Because especially the VA hospital is very particular about patient privacy, so you're supposed to use the secure system. And you know, patients, the VA hospital in the United States, they're poor people. So they don't all have that technological savvy. They have phones, like flip phone. They don't have a smartphone. Yeah, because they're poor. And so we have a system, but not everyone can probably use it. Right. Internet. Some people have no internet. Some people have a phone that goes like, you know, the flip phone. You know, remember the 1980s? Maybe 90s. Yeah, that's right. My patients, I said, can we do a video? They said, no, I don't have video. What kind of phone do you have? Yes, he is. He is so prolific. Yes, that's why I say his name 네.
One more minute. We're going to start early. Yes, yes, yes. So the program says we start at 4:40, but I'm going to use the chair's prerogative to start us a little bit early. I don't think anybody will complain. So the last session is designed to discuss how to present and publish your data, how to share your data in the most effective fashion. In this day and age, it's not only important for you to generate good data, it is also important that you share your data effectively so you get your credit, so to speak, for the hard work that you do to get to that point. So we wanted to showcase AASLD journal in terms of publication. And I have the honor of presenting to you Professor Carmen Wong, who is co-editor-in-chief of Hepatology Communications, an AASLD journal. And I'm so proud that one of our editors is from Asia. So she's based in Hong Kong University, professor in pathology, and she has really done a good job of editing our journal for us. So I am honored to have her here, and if you can have the slide up. She's going to talk about how the publication works So without further ado, please take away.
Thank you, Professor Kim, for the kind invitations, also the organizer. It's actually my first time to APASL meeting, and I hope I will have more opportunity to see you all in the liver meetings. So I am Carmen Wong. I'm from the University of Hong Kong, and I am in the Faculty of Medicine and also Stay Key Laboratory for Liver Research in Hong Kong. And I'm also the co-editor of Hepatology Communications. So just want to make some advertisement. And so Hepatology Communications is one of the AASLD journals. We are a sister journal of hepatology, and we have a very efficient and convenient transfer system from hepatology in a seamless manner. And one good thing is we have partner. So I'm the basic research editor-in-chief, and Dr. Elliot Tapper is actually responsible for the clinical research study. And we have a very strong editorial team with Yasuko also in the audience in our editorial team. And actually, Dr. Sabo is the founding editor-in-chief in Hepatology Communications, and she set a good foundation, and Elliot and I took up this task and because of her success. And we do have complementary expertise and network to ensure the work is evaluated professionally with the utmost care. Right, so currently we are receiving close to 1,000 submissions every year, and about 400 of the submissions are basic studies, and 600 of those are clinical studies. So there are a lot of people working on basic research as well. So today I would be more focusing on my perspectives on basic research study design. Right, so in order to make a good paper, so I would like to divide my talk into three parts. First is about the topic, second is organization of the work of the study, and the methodology. So all three are important components to make a paper great. So first of all, selecting the right topic is the first step of in preparing manuscript, right? So timeliness, it's very important. Most of the time, most good studies are time-bound. And also, you need to ask, when you design a topic, whether the topic is clinical relevant, and whether it is scientific novel, and whether your work will create impact and significance to the field. Right, so what are we looking for? So this is mostly for basic research. We are looking for any interesting studies that reveal the novel mechanisms that affect the liver functions, and this also include liver regeneration, novel mechanisms that contribute to different liver diseases, and also novel biomarkers and treatments for different liver diseases. So I show you a lot of emerging topics in basic research studies, including but not limited to the following. MASH method, we know that this is important. Liver regeneration, liver stonation, also very important topics. Immunology, it's burgeoning in any field, in any liver diseases. And also bile acid, microbiome, and liver diseases. Cancer immunotherapies, we know the clinical success, and so therefore this is also a very, very interesting topic. Microenvironment, not only limited to tumor, but basically the tissues of different liver diseases and heterogeneity within the tissues. And genetics, epigenetics, such as some new histone modifications, and nowadays we talk about not only DNA modification, but RNA modifications are very interesting topics. Single-cell RNA sequencing, spatial transcriptomics, and emerging omics techniques are all very attractive topics, and new experimental models such as genome editing systems, systems, mouse models, and also zebrafish models, etc. And importantly, we want to understand the mechanisms for drug response. For example, why some patients are responding to immunotherapies and where some are not responding. Right, so I told you about the timing of the publication is very important. So let me give you some examples. So tissue-based studies actually have inherent time limitations. For example, when you design a study, maybe like when you do a study 10 or 15 years ago when RNA sequencing has just emerged as the very powerful platform to replace cDNA on like microarray studies, when RNA sequencing on human HCC, it's very valuable. Probably it can boost your impact into like really like top journals. But you know, as we know that a lot of the data can be found in TCGA and also other public repositories. So therefore, this limits the value of just sequencing of primary liver cancer tissues. So TCGA data and other public repositories actually contain large amount of data, including genomic, transcriptomic, and also different clinical parameters. And also this would, to some sense, diminish the novelty and impact of the individual studies conducted solely on tissue samples. But I want to emphasize that we need to leverage and make good use and take advantage of this TCGA database and public repositories and integrate this data to your existing data as an additional cohort. Or if your lab does not have access to human samples, please make good use of the TCGA database because you can use those data and publish and include in your manuscript. And so if you really want to do tissue-based studies, you need to identify specific clinical questions. Now let me give you an example. If you compare steatotic HCC with non-steatotic HCC, probably it is a very attractive field this year or in the next 2 years. But you know, the novelty would start to decline as more publications are available. And so, for example, if you can acquire tissues from responders and non-responders for specific drugs in cancer patients, then this would be a more specific clinical question. And another solution is to provide more in-depth mechanistic studies because changes in tissues can be correlative. So you really need to have more experimental evidence to give complementary evidence to support what you observe in the clinical samples. Right, so now let us talk about the organization of your manuscript. So a good paper with good organization contains clear, concise, and logical flow of information. So I would like to talk about the following: abstract, introduction, results, and discussion. So abstract is the soul of the manuscript. It is one of the most important part of your manuscript. So make sure you spend a lot of time to write a good abstract. We will go into more details about the abstract writing. And introduction, you really need to provide the background to help your readers understand the context and significance of your study and the missing linkage. And also for the results, the result need to be appealing, tidy, and well arranged to give a good impression to the editors and reviewers, and supported by sufficient statistical analysis. And for the discussion, do not try to repeat the introduction. A lot of authors try to just repeat what they say in the introduction, but you need to have your own interpretation of the data and try to integrate your new knowledge into the existing literature and also highlight the novelty revealed by your study. Right, I also want to talk about the, writing a good title that can also create impact for your work. So I would like to talk about the searchability, acronyms, accuracy, and also the conciseness of the title. Right, so I actually learned it the hard way, so I'm going to share with you the lessons I learned, some of my publication, which did not receive good citations. So because we are also in the time of post-publication, right? We not only publish the work, we want to build reputation based on our work. So post-publication evaluation is also important, and a lot of time this can be revealed by the citations. Right, so here, this is a work I published at Cell Reports 2022. It's about a histone chaperone, which coordinates with a transcription factor HIF to mediate transcription program to adapt to poorly oxygenated cancers. And I only received 5 citations over the 2 years. So it's lower than the norm of Cell Reports. So this was not very successful. And the second paper we published at Guts, also on the same complex, but this study revealed how cancer cells or how the FACTs complex in cancer cells actually mediate oxidative stress response. Well, the title itself is more concise. I think the content also matters because this was published first. And also, I think when I go back to evaluate my own manuscript, I noticed that I made a mistake. I described hypoxia as poorly oxygenated cancers. So hypoxia is a more common terminology to describe oxygen deprivation, but I don't understand why I initially put this as a title. Just want to make it different or make it more unique, but we really need to consider all this, the searchability to increase the citations, the subsequent citation. So this, again, so I used another Cell Reports paper I published in 2022, so receiving same year. So this paper received higher citations, 36 citations. And I think the title is more clear in terms we talk about the technology used and also the mechanisms and also hypoxia in liver cancer. So the keywords have to be common. So use common terms for your title. Don't create fancy terms for your title because people cannot search your articles after you publish the work. Right, so the next thing I want to remind everyone is the use of acronyms. Right, so when I was preparing this talk, I looked into the literature and I found this very interesting paper at eLife. Maybe the font is a little bit too small. So I can summarize what they did. Actually, the authors analyzed all the publications from 1950 to 2019. And they actually performed some statistic and analysis on 24 million article titles, right? And so they concluded that some acronyms are very useful and widely understood, but many of the acronyms used actually hinder the understanding of the article and increasing fragmentation of science. So this is the finding in which they found 1 million acronyms in their database, but only 0.2% were used regularly. And 80% of the acronyms they found only have been cited or used for less than 10 times, meaning that a lot of acronyms are not used. And so we have to be aware of that. So let me show you some common ones, right, that you have to use, right? So hepatocellular carcinoma, HCC, this is very common, MASLD, MASH, and PSC. So this, that describe the diseases, probably you need to use the acronyms, but make sure in the first, in the introduction, in your abstract, you need to indicate what the acronyms stand for. And for example, for some techniques like PCR, you don't need to write polymerase chain reaction every time when you refer to the technique. And ELISA, these are very common techniques, right? But, I want to show you some weird ones that I encountered before. Cancer cells vulnerable to apoptosis, CCVA, and it's annoying to reviewers sometimes when they have to, especially when you have more than 10 acronyms in your manuscript, and they have to go back to the first page to look at the definition of the acronyms. For example, hypoxia-mediated immune response. I mean, this is easy to understand, but HMIR is very difficult to understand, and tumor-associated extracellular vesicles as TEV. So do not try to use new terms unless you are the giants in the field, all right? Okay, so these are some examples that I want to show you. Right, and also when you write a title, make sure that your title can accurately describe the findings of your work, okay? So avoid misleading statements and exaggerated claims and always be concise. Right, so I'd like to talk about these titles. They are more on basic research. The first one is Gene A Influences Immune Landscape of Liver Cancer. So this title is quite concise. It's short. However, if I want to give us like an advice, is try not to use influences because there's no direction whether gene A dampens or activates the immune response. So this is not so clear. The second one, gene A is the most important master regulator of immune response in liver cancer. So for the second title, I would comment that it is a little bit too exaggerating. So try to avoid using those words because some reviewers might kill your work because of this kind of like title. And the third title has some improvement. Gene A influences CD8 T cells and affects anti-PD-1 response in liver cancer. Now we know more detail about the work while it is still very concise. But again, influences and affects do not have directions, right? So I would prefer the fourth one. Gene A-mediated repression of CD8 T cells and impairs anti-PD-1 response in liver cancer. So there is a causal relationship between the repression of CD8 T cells and the anti-PD-1 response. And I think this title most accurately describes the situation, all right? Okay. Now, talking about the study design, so make sure your study has clear rationales so that can fill the current research gap and also employ new technologies if you can to review the unknown mechanisms that cannot be addressed in the past due to the technological hindrance. And third, thing that you need to consider is the logical connections between each point and each figures. So avoid jumping logics. So I'm going to show you more examples later. And make sure even for basic study, you need to include a reasonable sample size for statistical calculations. And usually for omics studies, we need to validate the omics with some other approach, complementary experiments. And again, we learn a lot from the morning's talk about statistical evaluation and its importance. Right, now I would like to tell you some of my advice about the papers that I've been reviewing. So on the left-hand side, so this is a very typical paper I received. A lot of the papers actually have this kind of structure. So a lot of authors will start from gene A and then using omics to link to pathway 1, 2, 3, 4, 5, 6, and eventually pathway 6 contributes to the disease progression. But a lot of times we cannot go back and cross-validate 6 back to 4 or back to 1 and even back to gene A, right? So this kind of study is loosely linked, and I would personally favor studies with a very clear rationale, a clear scientific question. So gene A contributes to a specific mechanism that contributes to the phenotypes or disease progression. And this has to be validated by multiple experimental platforms or experimental evidence to support such mechanism. This is more in-depth mechanistic studies. So now going back to the abstract, make sure you spend a lot of time to write a good one because an engaging abstract is appealing to editors and reviewers. And so in the abstract, you need to highlight the importance of the disease or the technology advancement, what is already known about the work, and also highlight the missing knowledge to be filled by the study. So also include clear and concise methodologies only for the key data, not everything, okay? And describe the key findings that support the author's hypothesis. And importantly, how the findings filled the gap. So the style, concise, avoid acronyms, and check for grammatical mistakes and typos, right? Because a lot of time editors would look at the abstract first, and then if there are a lot of typos, this is not a good impression for the editors for the accuracy. Like you cannot even proofread your abstract. How can we trust the data are accurate, right? So, in the rapid growth of information, I really encourage all of you to also, submit a visual abstract because it is attractive and it helps readers to retain the memory, and it also increases the citation of the work if they remember your work, okay? And so I'd like to show you two excellent visual abstracts. The first one is Prominent 1 promotes extrahepatic biliary luminal epithelium regeneration. Okay, so on the left-hand side, the authors actually show the hypothesis in which they suspect that PROM1 in the progenitor stem cells are responsible for the liver regeneration of point biliary injury. So the hypothesis can be summarized by this figure. And in the right-hand side, they summarize the results and also the experimental platform. They use PROM1 knockout mice, and they use organoid as the readout. And here they found they summarized their findings with this cartoon showing that the PROM1 knockout mice actually fail to regenerate, and also they show this dilated peribiliary gland structure, abnormal structures. Okay, so in one abstract, they show the hypothesis, methodology, results, as well as conclusion of the findings. So this one, and another one about liver regeneration. So this is, the title is Robust Protein-Based Engineering of Hepatocyte-like Cells from Mesenchymal Stem Cells. So what they show is that from mesenchymal stem cells, they can actually transform these cells with 4 transcription factors to make them hepatocyte-like cells. And so they implant this engineered hepatocytes into mice with hepatic failure. And on the right-hand side, show the key data, which is the survival as a readout, showing that the transcription factors engineered cells could extend the survival of mice with hepatic failure. So if I have to comment about this abstract, I would remove this network, which is not very necessary for the abstract, and also the H&E staining. So basically, but overall, this visual abstract is excellent. I'm not going to read out the abstract to you, but I told you the key components of the abstract. So I highlighted in yellow about the importance of the disease, what is already known about the work, and the missing knowledge, clear and concise methodologies, and the key findings and how the findings fill the gap. So all can be found in the abstract. So make sure you do a checklist when you do write an abstract. Right, so now I told you about organization, so I would like to talk about the final part, which is choosing the right methods. So I told you that high technology tools can be an advantage, but it can also be a disadvantage. So now, obviously, I ask you this question, whether high technology tools would give success or guarantee of success. So the obvious answer is no. So I would like to rewrite this formula by saying appropriate application of high technology tools, its equivalent would help you get successful publication. Right, so I would like to give you some example. So we heard about single-cell RNA sequencing in the morning. We know that this is one of the most important technology platform in the last 10 years. And this is a very groundbreaking technology that has transformed the scientific field, actually. And we can acquire a lot of information. Gene expression can be detected, the transcriptome can be detected at the single cell resolution. So it can help us understand the cellular heterogeneity within the tissues, and also the dynamics between different cell types in the complex tissues and organisms. And the experiment is very expensive, but it's very useful. It can help you generate a lot of useful information. But we also heard in the morning by Dr. Grace Su, so about, bioinformatics, right? It can be junk in and junk out, right? So we really need to have the biological sense when we analyze the data. We cannot only rely on bioinformatics. You can plot many graphs like cluster analysis. You can cluster all your cells based on their gene transcriptome, and perform heat maps, and you can identify the interaction strength between different clusters, etc. But a lot of time when we receive the comments from reviewers, they often consider that the data are too descriptive, And the reason is that a lot of time the researchers rely on the bioinformatics to give them some pathways to work on. But this is not the right approach, but instead you need to have a biological sense about the disease and leverage the single-cell RNA sequencing data to identify novel parts, but also you need to cross-validate with some biological facts with the single-cell RNA sequencing. So biological interpretation is actually the key to omics analysis. So in single-cell RNA sequencing, if you can identify some cell type or cell transitional state in the diseases, this is a good biological interpretation, and also identifies those relevant gene regulatory networks and also disease-related pathways. And importantly, I would highly encourage authors to validate their work with complementary experimental techniques such as IC, flow cytometry, and other functional studies, assays. And also importantly, try to integrate with different omics analysis to cross-validate. And also I would highly encourage authors to share the data and so then other people interested in the field can also make good use of the data because we know single-cell RNA sequencing is expensive, so we can be more effective for the field if there are available database that can be downloaded and be useful for some other people, also for reproducibility. Right. So I told you in this talk about choosing some attractive topic and how to organize your work, and also showing you some advantage and disadvantage of the new technology. Choosing the right method is the right approach for creating impact in your work. Right. Hopefully my talk can help you prepare your next study and your next manuscript. And I'd like to see you all again, and I'd like to take any questions. Thank you.
Give you a prompting question. So when I was a fellow or junior faculty, I had no idea what goes behind the scenes once I submit a paper. So once you receive a paper, what's your workflow, and what should people know to make sure that they have the best chance to get accepted?
Okay, so your paper, that's a very good question. So the paper would go to the editorial office and they would divert all the papers to the editor-in-chief. So basically, me and Elliot and I would look at all the abstracts, and we would browse through the abstracts and also look at the key data. So if we find the topic is interesting and the data seem to be reliable, then we would send to our associate editors like Yasuko in our audience, and then they would try to stand out. They would make a decision whether they would send out for external review or internal rejection. But editor-in-chief also play a major role in rejecting the papers, because we don't want to overburden our associate editors, because we're receiving close to 1,000 submissions every year. So you can see that you need to really write a good abstract in order to stand out among all these other abstracts that we're seeing every day. Actually, we would choose like 2 to 3 reviewers for external review, and then they would give you a score and they would recommend whether the paper would receive major revision, minor revision, accepted right away, or rejected right away. So basically, I haven't seen any paper with direct acceptance. So basically, you have to go through some kind of revision. That's kind of the routine. I mean, it's good that you have some experts to see your work, try to improve your work. But we are very reasonable. So we trust the reviewers, but we also try to be reasonable to the authors as well. So nowadays, our turnover rate is about 20 days, hepatology communications, with external revision. External review. So this is a very good rapid turnover rate. So this is about the workflow. So for the revision, I think I need another talk next time to show the authors how to make a revision in order to get through the reviewers and get through the editors. Those are the evils in the eyes of authors. But I mean, at the same time, they are really giving a lot of constructive comments to the authors. Right. And basically for hepatology communications, we're accepting around 20% of the submissions we are receiving, right? So 80% would be rejected. Yeah, so so we only publish the top ones, and so but I'm sure your work will be very attractive to our journal, right?
You put a great lecture on Asako. I'm from Yokohama City University in Japan. Not always using AI such as ChatGPT or something like that. Do you think that those tools will improve making papers or not? I just want to listen to your ideas.
Okay, so we gave a talk in AASLD, the liver meeting. We have the same question. Basically, AI can be used for language editing only, but we for the literature search, we really encourage the authors, just to use PubMed and use their own knowledge and experience for the writing. So, and of course, it's not possible to generate data from AI, at this stage. But I think for some minor language editing, I think it's acceptable. Yeah.
Thank you.
I'm just curious. I'm not sure if this question is appropriate, but yeah. So about the 20% like acceptable way. So may I ask how many were from like hepatology and then they transfer to?
Yeah, it's a very good question. So we actually we receive a lot of transfer because it is very convenient.
Right.
And also, I think you mean how many % of papers?
Yeah, just curious.
I think around 20% of papers, not high because some authors still want to try a few more journals before they come to hepatology communications. But a lot of authors would just transfer to us because they trust us, and also I think we do have a lot of transfer, and I'm accepting a lot of them because they actually they have gone through the external review, and we can evaluate the review based on our experience. Sometimes we do not send out the paper for external review again,
I see.
and just ask the authors to revise based on the reviewers' comments from hepatology. So this actually is an advantage because it really accelerates the publication time. And if you really need to deliver something quickly, be the first to publish, consider.
Of course.
Okay.
But would the chance would be higher if it is from hepatology?
Of course, I think the chance is based on the quality of the paper.
Right, of course.
And a lot of good quality papers are submitted to hepatology, and hepatology has limited space. And so, we are very thankful that we have this good source of papers, and I highly favor those from hepatology. Yeah.
Thank you. Thank you for sharing.
Thank you.
So it's my great pleasure to introduce the last speaker of this lecture series, Dr. Sadahisa Ogasawara. He is currently Associate Professor of the Department of Gastroenterology at Chiba University. He is one of the young opinion leaders, especially he is engaged in hepatic oncology. He treating, so many numbers of patients with advanced hepatocellular carcinoma. We will talk about the effective presentation of data. Thank you.
Thank you for kind introduction, Professor Tateishi. I'm Sadahisa Ogasawara from Chiba University, Japan, and welcome to Japan, everyone, and hope to enjoy Kyoto. Today, I would like to talk about effective presentation data, but my topic is like that sharing knowledge of writing academic papers. Some of my presentation overlapping with Professor Wang, so I'm just skipping and also talk about the next 15 minutes. I'm a clinician, and I treated about HCC patient more than 150 per year. And also the number of the patient treated per year is more than 700. So basically I work about clinician, but I tried to write about my article, and it is a number of the paper, 190 papers and 6,093. Also I received more than 300 types of rejection email, okay? Then next, so why do we write an academic paper? This is one of the points. So effort and courage are not enough without purpose and directions. John F. Kennedy. And so 4 reasons to write academic papers. This is my viewpoint. First one, sharing in advanced knowledge, okay? And to share the new findings and advocate the ability to social research with other researchers. This is really important. Also, through papers, constructive discussion and collaborative emerge within the research community. This is so important. The next time, ensuring research objective reasonability. This is, Professor won't talk about this point, but bi-direction research method and result in detailed paper, other researchers can verify and replace the result. This is so important for the progress in scientific. Also, this ensures the objectivity and the productivity of the research and enhance scientific credibility. This is so important. Also, career development as a researcher. Mostly, all of you are really, interested at this point, but this is one of the points why we write a research paper. Of course, publishing paper is important for the, who you are or what we have to do in next step. So this is important. Also, the collaborating to the society. By publishing research result in papers, the finding can be shared with returning to the society, okay? So especially in applied fields such as medical and imaging, new methods and techniques prepared in paper can be utilized in real-world application. This is one of my motivation for writing about academic papers. So what is the most important aspect for writing paper? So do you know that? This is clear. Defined as a clear research questions. This is what we are, really important point what we are doing. I told to the PhD student this point mostly. The clear research question is so important. So you should never search aimlessly. You can see the photos, that gold rush. So don't find gold on the river, okay? So picking topics and go to narrowing the topics. So this is so important. So if you cannot define the career research question, you have to do such as, gold rush people, okay? You have to find the gold in the river. It's impossible, okay? So with a real defined research question and the corresponding data result, it's been a result to address, the finish line of the turning your work into paper is within reach, like that. So these 2 points is important for the creating papers. So the headline for today is effective prediction data. So you can see that this is the checking submission guideline. You have to click here. If you click here, you can see these kind of information, file format, and also minimum resolution, clear file quality. You have to check this point before start preparing your manuscripts. And also give titles. And also, when I was 15 years ago, when I was a PhD student, we were taught that the title of the academic paper should be very specific. But now, as Professor Wong told that previously, create a title that is easy to find by searching engines. You have to increase your, citation numbers. Also, visual understanding contents paper important, like a graphic abstract. You have to create several, journals should create such a graphic abstract. But these are so important for the increasing number of the citation. You have to post this kind of graphic abstract to SNS. So, a lot of people can see that kind of data. So, and also abstract is, storytelling, emphasize novelty and importance, engage interactions, also quantitative result, and also further prospective applications and clear conclusions. This is I have already told by Professor Wong, so I'll just skip that point. But progressively narrowed down from the broader content to the specific to core research question that study aim to address is important for the creating introductions. General information such as hepatocellular carcinoma, the 6th most cancer of the world, such blah, blah, blah. And also, for example, what is HCC or what is HCV, then you have to approaching to the core objective of the study, the essence of the research question. And if you write the introduction, writing with an objective point of view, not subjectively. This is important for writing introduction. So this is always imaging such kind of structure when we writing about the introduction section of the research academic paper. Then result. The result is the main highlight. With a grievance presentation, it directly releases a positive evaluation. So the extract the data that guide the resolution of the research question from the multitude of the available data and create as a figure. don't indicate that table. You have to create a clear figures. So the tips of making figure is not so difficult, but simple and clear design and choose appropriate type of and also consistent styles and also clear label and titles. I think you can easy to find this kind of information in website or some of the books or something. So I don't do the such kind of detail, but also appropriate resolution and size and effective use of colors. And color is important. I ask color, sometimes I ask which color is most best to the OpenAIs. And then they told me you have to choose these kind of colors. So you can use the ChatGPT or some of the OpenAI for choosing colors. So because I'm not a good stylist. And also the present statics information and check the submission guideline. This is now for the making tips of the figures. And this is one of the, I just bring this is from Lancet paper. For clinical research article, genetic primary endpoint is illustrated as a figures. This is a primary endpoint is PF and OS, and just you can see clear figure right here. And the data can be summarized in table to reduce the number of entered in the article, because you can write down all of the adverse event in words or sentence. So you have to summarize like baseline characteristic, treatment related adverse event, such kind in tables. But I'm not a basic scientist, but almost all results presented in main text are expressed as a figure in the basic research. But in clinical research, you have to choose what you have to think about what data should be presented in the figure or what data should be presented in the tables. Then let's finish up the discussion section. And also when crafting the discussion, it is essential to summarize the main findings in the first part of the discussion section. This is one of the important key points for the creating discussions, okay? And provide an interruption of the result and also compare with the previous studies. Some Professor Tate said so, but I think so, or something like that. And acknowledge the limitation of this study. And also the suggesting future research directions, also emphasize the significance of the studies, and also clear and logical structure is important. Then, unlike introduction, the discussion section allowed for some of the subject statement. So you can write down your statement in this discussion section. So this is big difference between introduction section and discussion section, okay? Then, getting a paper accepted is not the end of goal, okay? This is important for me. The true assessment of paper begins once it is published, okay? You can see that the indicative assessment of impact of the article, that, impact factors or H index or top 10% article, recently top 10% articles are so important because, paper that rank within the top 10% of the most cited article in the same field and your year of the publication. It means if you're increasing a top 10%, article, those, also is so important for that field. So after, publication, the paper should assessed by the other, scientists. So not only the reviewers. So you have to think about not only to accept the paper, but also in the future after acceptance of your paper, okay? So this is my final slide. Maybe you are so hungry, so I'd like to finish that, but this one word of my presentation. As my clinician, we incur many patients daily, okay? So, and notice various clinical questions during our practice. So by resolving these questions and publishing the finding papers, we have a potential to help not only the patient in front of us, but also those whom we may never meet in person. And this is my motivation for working in academic department and creating papers. So thank you for kind interaction today. Thank you very much.
Congratulations for your nice talk. And is there anyone may have a question? So time is limited. Yeah. So we are going to the last part of today's workshop.
Thank you very much.
Thank you. So Professor Kim will make closing remarks and present the names of the awardee. in the breakout session.
If I can ask the photographer person, can you come for? We're gonna do some awarding, so if you can be in the middle part, that would be great. Yeah. Thank you, thank you. So my pleasure to be here, and we're going to announce recipients of the awards that we're about to give. And traditionally, it has been a travel grant for you to come to our meeting. This year, it will be in San Diego, and I'm not sure about the amount, but it's something along the lines of $1,500 to about $2,000 for you to utilize to attend our meeting. And your registration will be waived, so this will go to your travel expenses. And I would like to emphasize that these are, I won't use the term winners. Everybody did a good job. We chose the awardees based on a variety of factors, not just the science and the presentation part. We had a holistic assessment how you did your work and you presented your results today. So if you're not selected, it doesn't mean that your presentation or your science was bad. It's just that we had a holistic scoring system that we utilized to select the awardees, okay? And there will be one awardee per group. And the first, I'm gonna call out the moderators of the session to come forward and take a picture with the awardee. So one at a time. The first group is the HCC group, and the awardee is Hugh Ban from Vietnam, who presented risk factors and prognosis after primary curative hepatectomy in hepatocellular carcinoma patients. So if I can ask Professor Tateishi and Professor Su to come up. The second group was hepatitis group, and the awardee is Swati Thangaria. Is she here? Uh-oh. Is Swati not here? Okay. So that there was a runner-up, and the runner-up was Rex Hui. Are you here? The third awardee is from the third group, which was cirrhosis and portal hypertension. And the winner is, the awardee is Wasit Wongtraku from Thailand. Sarcopenia is associated with the risk of minimal hepatic encephalopathy in patients with cirrhosis. one final awardee is from the fourth group. And that person is Tsubasa Susumi, hepatic globular inflammation. Is he here?
He's on the web.
And it's on the way? Oh, he's only online. Oh, okay. Okay, so we will count him as present online. So congratulations to Dr. Tsutsumi. Hepatic globular inflammation is the most impacted prognostic factor in MAFL, a multi-center study. So those are the four. I think this is the most people who stayed until the last minute of the workshop, of the 2 decades of workshops that I have done. So thank you for your participation. Every year we come up with new ideas, and every year we appreciate the new generation of young investigators. They're getting brighter and brighter each year. So thank you for being here. I'd like to thank the faculty for spending the whole day working with the young investigators and the APASL organizers who have put this program together. And most of all, my partner in crime, Professor Tateishi, for your really tireless work to get this pulled off. Do you have any last word of wisdom?
Thank you, Dr. Kim, for everything. And it's actually a very tough work because I was noticed to organize this workshop just before the deadline. So, but thank for everything, for every judges and executive members and lecturers. I think it's quite fruitful, opportunity for everyone here. And I'm confident that these, sessions and the lectures, contribute to your career development. Thank you very much.
Okay, let's go home or have dinner. Thank you.